Hello, I'm Dipti Itchaporia, and I want to welcome you along with Dr. Sobi. The two of us would like to welcome you to our Middle East conference. We're excited to have you all here virtually with us. And I'd like to introduce Dr. Sobi to say a few words also.
Yeah, thank you, Deputy, that you accept this to share with us the ACC Middle East 2020. Actually, we have a problem because of a COVID. It should be done in October in Cairo, but we decided the chapter and the society and the ACC to be delayed to next year. And so we decided to make another issue, which is 4 waves, ACC Middle East 2020. And this is the first webinar series. With Dr. Magdi Abhamid and myself and the deputy, arranged for conference calls with the ACC team in order to have different topics in the ACC Middle East. Every month we have one. So we have in August, September, October, November, and then we finish this ACC Middle East. I hope this is not from Egypt. It's all for the Middle East. So we will have speakers and chairmen coming from all areas of the Middle East. I hope to enjoy, and please send your questions on chat so the chairmen will distribute the questions to the speakers. Deputy?
Yes, and so we want to introduce our first speaker, Dr. Roxana Marin. We're so excited to have her here. And as you know, she's a professor of cardiovascular research and outcomes at Mount Sinai Hospital in New York. She's a professor of medicine and population health sciences, director of the Interventional Cardiology Research and Outcomes. And we're really excited to have Roxana speak to us about managing the high ischemic risk patients with complex anatomy. Roxana? Welcome.
Thank you. Thank you all, ladies and gentlemen, and most importantly, Dr. Sopi and Dr. Itchaporia. What a wonderful occasion for the ACC, the American College of Cardiology, and to be with you as our vice president of the college and be able to deliver this speech. I'm really, really very proud, and I thank you all. What I'm going to do is take my so that we don't have any problem with broadband, so that we could have a good discussion. And I apologize for my poor internet connection. United States does not have great internet connection in the rural places in the world do not have it, and especially here in America. So it's not just in other countries. So you asked me to talk about the high ischemic risk patient, and thank you for that challenge, because I'm constantly talking about it. But it's really important. Let's make sure that you all know about my disclosure study, planning some of the work from the complex patients and lesions there. But that study was sponsored by the Icahn School of Medicine at Mount Sinai with a grant from AstraZeneca. So when Andreas Grunzig first showed us PCI, those early days, we had simple lesions, a single small, balloon angioplasty, then moved to stenting, and a relatively young, healthy population. It wasn't until later when Dr. Hartzler started to push the envelope into when Dr. Hartzler asked to in a much more complex multi-vessel disease, where we started to engage in PCI and multi-vessel and high-risk patient population. But the truth is that this growing high-risk population is ongoing. There are important patient comorbid conditions that previously would never be included, but now our patients do have comorbidities that include diabetes, chronic kidney disease. They present with acute coronary syndromes, with bifurcation lesions, CTO, left main, and very importantly, also have ventricular dysfunction with low ejection fraction and high pulmonary pressures. These high ischemic risk patients are the following. There are both angiographic and patient factors, as I discussed, but it isn't every day. We see patients with multi-vessel disease requiring many stents, long stents, and of course we see CTO and bifurcation, and of course, very importantly, those same patients have these important comorbidities that deems them high risk for ischemic complications, myocardial infarction, spontaneous myocardial infarction, as well as a stent thrombosis. Is there a universal definition for complex PCI? And the answer is no. Bobby Yeh presented his work showing and describing a criteria of left main more than two or lesions or vessels, long lesions, bifurcations, saphenous vein grafts, thrombus. And then from our group, is being used a lot. And depending on which criteria you use, the prevalence is really up and down. From our registry data, Chandrasekhar presented the presence of left main bifurcation, calcification, and long stents, which occurs in about 50% of our patients as the complex PCI patients. But the bottom line is there is general consensus. ACC AHA lesion types have been used to try to show the anatomic complexity from low risk to moderate risk to high risk, and then actually equating that to the success of PCI. But this is back in 1988, and we've come a very, very long way from that. There's no question that one of the things that we do know is that preparing preparation is incredibly important. We have now made great strides in improving our stent technologies and our delivery systems. But the fact is that these complex lesions with large plaque burden, often calcific and undilatable, will require some previous treatment prior to stenting preparation. And although there's never been clinical trials that have shown that preparing these lesions gives us a better outcome, there's no question that in order to gain, furthermore, optimal vessel preparation by enhancing the lesion compliance and improving the stent delivery and optimal stent expansion that has been shown that allows for less of a trauma to the vessel may have an important outcome down the line. And we have been doing this with intravascular ultrasound guided implantation, showing that there is some evidence that by using important criteria to optimize deployment, using minimal lumen areas and looking for no edge dissections and allowing for intravascular imaging to enhance our ability to give the best possible early result, there could be an important relationship to target vessel failure and optimizing a PCI outcome. In fact, in a meta-analysis of about 3,300 randomized patients, there is some evidence that IVUS guidance can improve outcomes. Has there ever been a large enough prospective randomized study showing this? Answer is no, but if the evidence is beginning to come more and more in enhancing our outcomes in improving our results in complex lesions. Furthermore, I think it is important that to note the outcomes on the current generation DES, and this is work by Giulio Stefanini in JACC a few years back, showing that increasing complexity of the lesion increases the target lesion failure, which has to do mostly with increased target vessel and target lesion revascularization, as well as increasing some of the spontaneous MIs. And you can see that here, simple versus complex, worse outcomes in complex patients. And even though with the newer generation drug-eluting stents showing that these have a better outcome or similar outcomes, we do have some increased MACE in relationship to complexity. So what does this mean? When you have a complex lesion, we will be actually prolonging dual antiplatelet therapies. And it was the DAPT study that asked the seminal question, is there a benefit in extending dual antiplatelet therapy beyond a year, a longer treatment? the longer treatment of patients with dual antiplatelet therapies in this largest ever study, double-blind, placebo-controlled trial, did show that by prolonging dual antiplatelet therapies, you will reduce stent thrombosis and major adverse cardiovascular and cerebrovascular events such as death, myocardial infarction, and stroke. And you saw that very, very nicely, thienopyridine compared to placebo, but no difference in cardiovascular mortality. Why is that if we did such a good job? The fact is that when you prolong dual antiplatelet therapies to prevent against ischemic outcome and ischemic complications, you will increase bleeding. And that's exactly what was observed in the DAPT study, an increase in bleeding, moderate to severe, ARC-3, ARC-2, and moderate to severe gusto. In fact, when we look at the meta-analysis of DAPT duration after complex PCI with pooling close to 10,000 patients, there is a very, very important message that yes, by prolonging DAPT, you will reduce MACE, but you will increase bleeding. But there is this very important overlap. These same high ischemic risk patients also have bleeding risk, and it goes vice versa. Dr. Sopi will tell us that high bleeding risk patients also have ischemic features. How do we balance that? How do we make sure that we could make the best possible decision on our patients with complex PCI in making sure we tailor their dual antiplatelet therapies? An individualized approach of looking at ischemic versus bleeding risk has to be done. One way is to perhaps think about dropping aspirin in the dual antiplatelet, going to a single antiplatelet therapy. And this is what the global leaders investigators did. And in fact, in their analysis of ticagrelor monotherapy after a month of dual antiplatelet therapy in complex PCI, these investigators did show a reduction of the overall patient-related outcomes, where, in fact, in the primary endpoint, in complex PCI, there was a reduction. And therefore, it did show that this important new way of innovative approach of dropping aspirin might have some important benefit. It's important to note, though, that global leaders, investigators, did not show the statistical significant benefit of ticagrelor monotherapy compared to the control arm of standard of care in the overall patient results, but they did see it very, very nicely here in the complex PCI patients. What about the ticagrelor monotherapy in complex patients? The Twilight study, in a double-blind, placebo-controlled fashion, randomized 7,119 patients to ticagrelor monotherapy versus ticagrelor plus aspirin after 3 months of ticagrelor plus aspirin. In that trial, we did show a statistical significant benefit of reducing bleeding by going to ticagrelor monotherapy without increasing ischemic harm in the overall patient population. So the big question was, what about complex PCI? Are we harming patients who have a complex PCI? We used the criteria of the complex lesions that I previously showed you and found that we enrolled about 3,000 patients who had a complex PCI and randomized 2,620 of these patients to ticagrelor plus placebo versus ticagrelor plus aspirin for 12 months. In that analysis, in that pre-specified sub-analysis of complex lesions, there was no statistical significant interaction for the treatment effects on bleeding and ischemic endpoints between complex and non-complex groups. But you can see right here that ticagrelor monotherapy in terms of bleeding certainly absolutely reduced bleeding, and there was no real signal of harm, although the confidence intervals for stent thrombosis are extremely wide in this very small, rather small sample size, even though we have 2,600 plus patients. So the take-home messages here, I hope that I've delivered, is that the number of high-risk patients undergoing PCI, complex PCI, is absolutely increasing. New generation DES with current technology of preparing the lesion, using advanced imaging, using physiology-guided treatment of the indicated lesions for revascularization has resulted in an excellent and better prognosis of these patients. A short course of dual antiplatelet therapy followed by ticagrelor monotherapy could be a way when we are dealing with that same complex PCI patient in whom we're worried about the bleeding complication. And so maybe perhaps dropping the aspirin and maybe even thinking about a lower dose of ticagrelor in those very bleeding patients could be something for us to mention. Thank God we got through this. Thank you.
Thank you, Roxana. That was great. I guess there's a lot of things that I think we have a few minutes to have a discussion, and I wanted to ask you about the fact of optimal vessel preparation that you mentioned. What does that really mean? So you can identify a complex patient, because we know those high-risk patients, but what would, as an interventionalist, what would they be doing when they're thinking about optimal vessel preparation?
Yeah, so it's really important that in any complex, when you have a complex lesion, it's really, really important for the interventionalist to be sure that that patient leaves the cath lab with the best possible result. It's a lot easier to accomplish that when you have a focal lesion in a non-calcified large vessel. It's a different story when you have a calcific, diffuse disease lesion that you have chosen to perform PCI. And if that's the case, and you decided that your revascularization strategy after a heart team approach was PCI, then it's really important that that patient leaves the lab with the best possible result. And that might mean vessel preparation for better stent expansion. So if you have a calcific lesion, don't go in and just put a stent and be happy with an angiographic result. That might be an underexpanded stent, and that it's really important to prepare that lesion, perhaps with rotational atherectomy, lithotripsy, or even other, preparation of non-compliant balloon using the cutting balloon technology to be sure that at the very least we have the best possible stent expansion, and then using intravascular imaging to make sure that you don't have edge dissections, that you have full apposition, and that you actually feel good leaving the lab at, yes, this was the best possible result that we could get in a complex bifurcation lesion, long lesion, multiple stents. It's really important to get a good result.
I have a question to Dr. Roxana. Can I ask a question? Yeah.
Absolutely.
Yeah. Thank you for your great presentation. You mentioned in your take-home messages that PCI guided by advanced imaging results in better prognosis. But in this region, this part of the world, we don't routinely use advanced imaging during PCI. So what do you think? Should we still go with the policy of dropping out aspirin after 1 month?
Yeah, so look, in Twilight, we had a global study, and the use of intravascular ultrasound was about 12%, and intravascular imaging. And I am saying that if you are going to, I'm telling our interventionalists that if you are going to push a patient away from CABG and grab it for PCI, then you better do a really, really good result. And you better make sure that you feel good about what you have done and how you have chosen to treat this patient with PCI. And if that's the case, then you should try your best. If you're not using intravascular ultrasound and don't have access to it, I can tell you that you're still going to be okay, because that's what we showed in Twilight. About 15% of the patients received intravascular ultrasound. And we were still able to reduce bleeding without ischemic harm with over 7,119 randomized patients in a double-blind placebo-controlled fashion around the globe, 178 centers, 11 countries. So I feel confident that if you got a great result and you know that you did, you're an experienced, which I know you are, experienced interventionalist, that you will then feel okay to drop the aspirin. I'll tell you, when I don't feel okay about dropping aspirin, if my P2Y12 inhibitor is clopidogrel, I don't know that I feel confident doing that, knowing that there are about 30-40% of the patients that might have the CYP2C19 allele and have non-responsiveness to clopidogrel. So if you have a complex patient with a complex lesion and you're hoping to drop aspirin and you're worried about their bleeding, so therefore you put them on clopidogrel plus aspirin, I would not drop the aspirin unless I knew that they were actually responding to clopidogrel. I have no data to prove it. The Taylor PCI, unfortunately, was negative, but that's my practice at the moment.
Okay, thank you.
We had a question from Oman, and that was when you said shorter course of dual antiplatelet therapy, how much short is short? And what is your own practice when you do shorter dual antiplatelet therapy?
So let me make sure that I'm clarified to my colleagues and friends in Oman. Hello, thank you for your question. It is really important that you do not walk away from this lecture thinking that everyone should receive a dual antiplatelet therapy that's short in duration. I really do not want you to walk away with that. We have evidence and we know that if a patient is at a low bleeding risk, presents with an acute coronary syndrome, that patient should receive 12 months of dual antiplatelet therapies, whether they receive medical management, PCI, or CABG. You should be educating the patients to be on that because it will be protective. In fact, we have now learned from the COMPASS trial that down the line, even further out from their PCI, after their myocardial infarction, that even giving them a low-dose oral anticoagulant could actually reduce both limb and cardiovascular events and reduce mortality. So I'm not here that we should be shortening the duration of DAPT for everyone. What I'm saying here is that we could be innovative in our approaches because a prolonged DAPT produces more bleeding. So can we drop aspirin that is a pretty much a good GI sluffer? It does a great job in direct GI toxicity and gastrointestinal bleeding, and keeping the patient on a potent P2Y12 inhibitor. And in those patients who are at very high risk for bleeding, you can even consider clopidogrel, test them if they're responding, maybe they can do well. And the duration of that could be 3 months is what we studied in Twilight, but it could go down to a month in those who are extremely at high risk. We've already learned that from Leaders Free, from all the multiple trials that have been done on high bleeding risk patients, and that we can do this safely for stent-related complications, but understanding that when you shorten the duration of DAPT, even in the high bleeding risk patients, you do expose them to a little bit of an increased ischemic event. So it's that balance that you have to make, and very difficult decision-making processes that go into our heads when we're seeing these patients. I hope that's clear.
Dr. Shahab, do you have any questions?
I think that's great. I think Roxana has taken us through an excellent, I think tackled all the questions we had. So I think better to move to next speaker, and so we have a balance. Okay, bye. Okay, Assalamu alaikum rahmatullahi wa barakatuh. This is Abdullah Shihab, and again, it's my really great pleasure to be a part of this team. And I had the honor and the privilege to be the president of the ACC Middle East in 2017 and 2019 in Dubai. But I think Dr. Subhi did a great job to bring us together even during this pandemic time. So already Dr. Roxana covered the acute coronary syndrome with high ischemic risk. So what about acute coronary syndrome with high bleeding risk? And this is going to be presented by our colleague, Dr. Muhammad Subhi, who's got many hats. He's the was president of the Egyptian Society of Cardiology, and currently is the president of CV Rep and also governor of ACC chapter. And Dr. Muhammad, we're looking forward to your, I think, complex talk.
I think it's difficult to speak after Roxana, but I will try. I know that this is the speciality of Roxana, but let me allow that I didn't know that what Roxana is going to speak, but I have to take the first slide from Roxana. This is definition of bleeding. This is your definition, Roxana, about PARC definitions. Actually, there's 5 types of bleeding. Snow bleeding, 0, 1 is bleeding is not actionable. Type 2, any clinical overt signs of hemorrhage is actionable. Type 3, A or B, overt bleeding plus hemoglobin 3 to less than 5 or less than 5. Type 4, cabbage-related bleeding within 48 hours. And type 5, probable fatal bleeding and definite fatal. This is the PARC definition. So it's how to score bleeding risk. We have a lot to say about this. We have Action, Crusade, Acuity, Horizon, Paris, Precise Depth, and BLEMAX. So this is the ARC or Academic Research Consortium for High Bleeding Risk define HBR or high bleeding risk at the risk of PARC 3 or 5, bleeding more than 4%, of intracranial hemorrhage more than 1 or equal 1% at 1 year. So then come to the duration. The duration differs. We have 2 scores for duration. It's called precise depth at time of coronary stenting and depth score at 12 months. So precise depth, including hemoglobin, white blood cells, age, creatinine clearance, prior bleeding, score points. Is score more than 25, short depth, less than 25, standard long depth. Depth, it's after 12 months, and you have a lot in items here. Score more than 2 long depth and score than less 2 standard depth. This is also mentioned by Roxana. So definition, scoring, assessment of bleedings. There are 3 studies, important studies, this study, comparing the tacrolimus versus VER, showing that drug-eluting tacrolimus is better decrease death, MI, and TVR in 1,600 patients. Leaders-free, decreasing cardiac death, MI, syndrome using drug-coated stent biofreedom. And senior study, decreasing death, MI, stroke, TLR, actually comparing with the bare metal stents. So then comes, this is generally the factor which is called high bleeding risk PCI, 1 factor hormone, elderly age more than 75, or anticoagulant plan for after PCI, renal failure, less than 40, planned surgery less than 1 year, anemia, hemoglobin less than 11, hospitalization bleeding within 1 year, long-term non-steroidal, severe chronic liver disease, stroke within 1 year, cancer diagnosed or treated within 2 years, 3 years, thrombus. So we have a lot here. We have 11 factors. But this comes recently, the Asian Pacific Society of Cardiology, showing that you have to simplify the bleeding risk assessment into ABO. A means age, frail, elderly, advanced age, life expectancy less than 1 year, and this must be accompanied by 1 additional risk factor. Bleeding with a spontaneous intracranial hemorrhage, recurrent GIT bleeding, hemoglobin less than 9, PC intracranial traumatic hemorrhage, recent surgery, approximate needing for surgery. This is called for bleeding. So you have to have a history of bleeding, frail age, and organ dysfunction, or you can look for the liver, the kidney, the bone marrow, the stroke, and these are the organs. So if you're going to remember the bleeding risk, go to ABO. So what about your patients in the ECS planned treatment strategy? For the ACS PCI, you have to preload or not, using radial access or femoral, target vessels, intravascular imaging, and heart team. This is very important to look after the PCI strategy. Then you have risk stratification of patients. If the patient had the risk scores for high bleeding risk or no clinical judgment, then bleeding prevention. These depend on the duration of DAPT, intensity of DAPT, using PPI, counseling, then bleeding. If the patient is a bleeder or a history of bleeding, so recurrence and prevention important through DAPT shortening, DAPT de-escalation or monitoring. But if there's no bleeding, you can continue as DAPT continuation. Let's go for this non-ST. I will give you an example of non-ST. Non-ST or patients, the ACS invasive or the B12 in non-STEMI patients, ACS conservative, early in non-ST, we have different trials. If using ticagrelor, we have a plateau and basically the deepest study in going. And then prasugrel, Triton, TIMI38, Triology, ISARI-ACT, and ACOS. So we have trials for this kind of use P2Y12 in non-STEMI, whether invasive, ACS, conservative, early. Preload or not preload, already solved by ACOS PCI, that if you have no pre-treatment, with pre-treatment, there is no difference in CVD death, MI, stroke, and the risk of bleeding is decreased of no pre-treatment. So according to ACOS PCI court, no pre-treatment for non-ST. What about the antithrombotics in high-risk bleeding? If you have non-ST with admissions, give aspirin, and PCI and cath labs, give enoxaparin, then endo PCI ending with clopidogrel 300 milligram, loading dose, then 70 milligram, or prasugrel 30 milligram, loading dose 5, then 5 milligram maintenance dose. I give you an example of patients how to solve this in a patient practice. This is an 82 years old male, diabetic type 2, with atrial fibrillation, history of TIA 6 months ago, history of GIT bleedings 4 months ago, angina at rest with positive troponin, ECG diffused ST depression 1 meter in anterior leads, echo Doppler hypokinesia of anterior wall, ejection fraction 45%, eGFR 38, coronary angiography within 4 to 6 hours of presentation. We can see that this led D1 true bifurcation, 99 with normal right coronary, good collaterals to LAD and D1. Then come to the case management, the PCI versus CABG, the syntax scored 19, which stand for PCI if you use it, adapt for how long. Then we come to the PCI. According to the guidelines, this patient syntax score 22 is diabetic, so PCI 2BA and CABG 1A, but the patient prefers 2PA. So why PCI? Because this is have a severe comorbidities, is advanced age, frail, reduced life expectancy, and the syntax scores 20. So PCI was chosen. Which stent to use? We can look to these high bleeding risk categories. This patient is elderly, they're more than 70. He is renal failure, and patient in hospitalization bleeding within the past 6 years, and they have a history of TIA stroke. So which stent to be used? We either BMS, drug-coated by Freedom and Onyx. Do you have a guidelines for this? According to European Society guidelines, by Freedom and these thrombolysis stents for 1 month can be given. So we decided to choose a stent here. It's not bare metals because this is 2-wire LED diagonal, pre-dilatation of both, and then more pre-dilatation, as we can see for the patients. And then we decided to put Stentec Onyx for the stent deployment, 3mm 33, LED, a long plaque overlapping, and then recrossing the wire, the pot, and then opening the struts of the OCLD because of the plaque shift. And this is the final angiogram, ending with 1 stent with STEMI3 flow on diagonal, or just an osteal 30-40% and diagonal. So we, according to the choose the stent, we have Onyx 1 summary slide here. There's no difference between BioFreedom and Onyx. The one global study that actually was safe and effective in highly complex bleeding with 1 month durations. And then recently in the last ACC, Onyx 1 clear, it's compatible, can be used for 1 month durations. Then DAPT, comes the problem with the DAPT. How long you decide the DAPT durations? What the guidelines said? The guidelines said this patient is ACS with drug-eluting stents with high bleeding risk, either aspirin or clopidogrel or aspirin ticagrelor for 6 months duration, class 2A, B. According to DAPT duration, this is slide showing the difference between the American College of Cardiology and the European Society of Cardiology. For our patients, either an ACS, a DS, we can go to 3 to 6 months because this patient is high risk of bleeding. According American College, according European, up to 6 months because this is high risk of bleeding. So can we make a minimal DAPT duration? Actually, it could be up to 3 months stable in a stable patient for 1 month. So which antiplatelet to stop? Then come the questions I think Roxana said in high complex lesion, you can drop the aspirin. This is the high bleeding risk in 4 studies. They have stopped P2Y12 and they're keeping the aspirin in this and leaders, senior, and Onyx 1. But with the other 3 trials, they stopped the aspirin, stopped DAP2 and Smart Choice and Twilight, as just Roxana said, for about 2 to 3 bleedings, primary outcome here. So what's the difference here? We have 4 trials, as Roxana said, global leaders, 15,000, Smart Choice, 2,000, DAP2, 3,000, Twilight, 7,000. So actually here, the P2Y12 is 17 trials. So totally, here patients is 20,000 patients, and here is the 46,000 patients. So it's the big numbers for continuation of P2Y12, of continuation of aspirin stopping P2Y12. So what the guideline said, guideline remove P2Y12, not aspirin after PCI. High risk coronary patients, this patient is high risk, yes, and they need for life. What needs to life? This is a trial that the Charisma trial, ZAP trial, Pegasus trial, Triate trial, Triology trial, and Themis trial, and Compass trial. All these trials, these are long aspirin for high risk coronary artery disease patients. So are you going to remove the antiplatelet or not? We don't have till now the actual answer. Maybe aspirin, maybe P2Y12, but still we have P2Y12 to stop after and then continue with aspirin. So don't remove the last antiplatelet drug in PCI patients. This is evident in POISE 2 for the death in minus T. You can see the aspirin is effective, although there's major bleeding is more or less the same in POISE 2. So my final thoughts or conclusion, that high risk of bleeding needs proper assessment. You have to score bleeding. You have to, and then either for the age, for the organ, patients or the bleedings, and then choose the best stent with short duration. You have either bare metal stent, but actually this is for reason is high. So you have either Onyx or you have Bifreedom, but actually Onyx is a proper drug-eluting stent, so it could be one of the best according to the Onyx trial. Then strict guidelines for depth for short duration. We can strict whether SES or this is not SES going this. And so finally, we have to personalize, called personalized medicine, and the best is the safety of the patients, prevention of restenosis, optimization or PCI optimization, and finally, a short depth duration in order to prevent bleeding. Thank you very much. And actually, this CardioX 2020 promised you to be done in a hybrid way in 5 to 9 of October in Alexandria Bibliothèque. Thank you very much, and see you soon.
Outstanding. Thank you very much, Mohammed Subhi, for a great, I think, again, overview of high risk of bleeding among acute coronary syndrome patients. So, what are our concerns, Mohammed? Is why we need to shorten? I mean, in addition to the bleeding, I understand that, but what's the problem of shortening it? Is it we're worried about the stent thrombosis, or are we worried about other native coronaries which is maybe at risk? Why are we worried about shortening?
It's a very good question. Actually, if the patient is not high risk of bleeding, personally, I continue with the P2Y12 for a longer time, because most of our patients are high ischemic patients. As Roxana said, there is a table of high risk. It's very rare to find a low ischemic risk patients in our situation, particularly in our Middle East era. That we have a diabetic patient, we have multi-vessels, we have long stents, we have a bifurcation left main. So we have a lot of ischemic. So we are continuing. It's not the aim is a stent thrombose, because stent thrombose actually will be 1 month. But actually, if you remember in the era, maybe 10 years ago, about the late stent thrombosis of this. So why not stop? We don't stop. We are not going to stop P2Y12. If we take a girl, it's 90 twice for 1 year and 60 twice for, according to biggest trial, for 36 months. If you have a clopidogrel, we can continue according to that. I know that Roxana will have an opposite to this, but let's go to discuss, and that is a very important point. For me, in practice, I continue P2Y12 for a longer time with aspirin, and you can stop for 5 days if you have a non-cardiac surgery. This is the main. If they have a high risk of bleeding, it's another story. The safety of the patient is more important than the progression of the disease and the longer time.
If I follow that with Roxana, you've done a great, very refined randomized clinical trial to help us with, with this shortening the dual antiplatelets. Where's the problem? Is it aspirin the problem, or is it new antiplatelets the problem? Or what should be our practice? Away from the scoring and all this, which I think is difficult in our practice to follow.
You mean the bleeding?
Yeah.
You mean the bleeding? The bleeding comes from the dual, the depth. There's an argument about the aspirin for 4 trials, 17 trials saying that it's P12. So we are not sure till now the proper answer. The guidelines stop P12, but in 4 recent 4 trials they stop the aspirin. So maybe individualize according to the highest. If you have a high ischemic risk, I believe you can continue. Maybe according to the COMPASS trial, the rivaroxaban can extend the indication to minimize this kind of bleeding if you have a small dose of rivaroxaban together with the aspirin rather than giving P12. I don't know that Roxana can add to this or not. Can you open your mic, please? Unmute, please.
Roxana, you're on mute. So I think that one of the questions is, when you are worried about bleeding, do you stop the aspirin like Roxana is saying, or do you decrease the duration of the dual antiplatelet therapy? And we certainly are seeing more and more trials that talk about shorter dual antiplatelet therapy. Mohammed, you mentioned that about doing 3 months if you're worried about bleeding risk. But if you did that, seems like with what Roxana's presenting, it's saying stop aspirin but continue the P2Y12 for longer versus decreasing the dual antiplatelet therapy. So the question is, what is your practice right now to do?
No, I practice. If there's a bleeding, I will stop P12, but continue with aspirin if it's not high ischemic risk. If the patient high ischemic risk, I stop the aspirin and give him P12. According to that, so we choose this patient high bleeding risk alone without high ischemic risk. So I give stop P12. If it's high ischemic, high bleeding, so I stop the aspirin and go for P12.
Roxana, your mic is off.
Unmute.
Unmute. Roxana, you're muted.
Unmute.
She can't hear us.
There's a question, Mohammed, is where does the low dose anticoagulation fit into our PCI guidelines for patients?
Low dose?
Low dose of anticoagulation. Like rivaroxaban 2.5. Where do we fit this into the PCI?
But rivaroxaban in COMPASS trial, this is, for example, this is after 1 year. We can continue for this patient high complex anatomy and also those who are peripheral disease. So peripheral and coronary and disease. This is the COMPASS trial. But the problem that I didn't mention in my talk about giving NWAC if you have a problem of giving triple therapy. How to continue this triple therapy, which one do you going to stop? You know that we have for the last trial about Augustus trial, about Redual and Pioneer trial, they stopped the aspirin and they given only P12 with NWAC. This is good for still in the guidelines, but this is if you have a patient with atrial fibrillation, not paroxysmal atrial fibrillation, the Schett score less than 2. If more than 2, you have to give this with P12. We have the high ischemic risk. This is after 12 months, you can stop P12 and go for aspirin with NWAC for longer time.
Yeah, the other options, Mohammed, is the DCB, balloons rather than just going with a stent. If you are worried about the stent thrombosis, what do you think of that?
Yeah, you are completely right. But this is still in the guidelines. Instant stenosis. Yes, it's class 2B, but still using in recent trial in de novo lesion, in diffuse disease, in bifurcation of the osteal lesions. Maybe osteal right, maybe osteal diagonal, maybe osteal. But in osteal CX and osteal OM, I didn't use this DCP. So DCP still, but I think it needs more trial. But I agree completely what you said. It needs more trial to be stabilized.
Do you have any questions?
No, I think that so there was somebody else that again said they wanted to know if we still had some sort of consensus about what we do. But I think that I think Mohammed, you really addressed that, because I think there's a lot of different competing issues. So I think you really have to assess whether there's a high ischemic risk or whether we're talking about bleeding risk. And I think we have to look at the different strategies. There's a lot of data out. I'm glad you mentioned the triple therapy, because AFib comes up a lot in these patients. I think there's a lot of data that supports that we do that we do triple therapy for a month and then maybe stop the aspirin and continue the anticoagulant as well as the P2Y12 inhibitor.
Yeah.
So, anything else that you wanted to add, or Roxana, if you could come off mute, that you could add?
No, I think that's a really, really good. That's a really very, very good synopsis of the fact that one size does not fit all, and that we do not have all the right answers for everyone. But what we do know is that we have to really weigh the risk of bleeding and ischemia and very seriously ascertain both and understand and talk to our patients and discuss these things and explain it to them. Often the patients are taken out of the equation, and that to me is a very, very big mistake. The more educated patient is the much better consumer of healthcare. And I think we really have to continue to educate and bring them into the fold so that they are adherent, so that they report to us all of their important variables that have to do with both ischemic and bleeding risk. And then it comes to us to try to really navigate their course of antiplatelet therapy using these risk parameters and working with them and the referring physicians to make the best possible decision moving forward, understanding that you may not be right 100%, just like we're not pretty much for everything else that we do in medicine.
Roxanne, I'm going to pin you one more time.
Can I add something? Yeah.
Go ahead.
Okay.
Go ahead, Mohammed.
And they have a question here to me. That's why I'm stimulating me to have a comment. Do you recommend 60 milligram TECA for a high-risk bleeding patient during the first year? No, because we don't have a trial. The Plateau trial is 90 milligram twice daily. Maybe in 9 months, it'll be 6 months to go together. Then continue 60 twice according to Vegas. We have trial, so we have to obey the trial. The second that for this patient, if you have to make a high bleeding risk radial approach. Sometimes you have de-escalation. I mean, the problem of de-escalation is not because it's a very strong and potent P2Y12 is ticagrelor and prasugrel. So if you have a bleeding, I think you have de-escalation to clopidogrel. You have to switch, no matter what you have, but you have to switch into clopidogrel in your patient if you have bleeding for this. Don't restrict that you have to have this drug, but it's a potent drug, particularly after 1 month for taking this patient. This can be my final thoughts to high bleeding risk. Okay.
Deputy, I think. Any other questions?
I think this was a great discussion. I think the key questions are going to be, I think, more data to see if we're going to get rid of the aspirin, or are we going to continue to do shorter and shorter dual antiplatelet therapy. And I think that's really the questions on the table. And I think, Roxana, you were sort of presenting the data for stopping the aspirin and continuing the P2Y12, but the more potent P2Y12 versus Mohammed, you sort of presented the data for the shorter dual antiplatelet therapy. Any thoughts on that, Roxana? Because I think Mohammed addressed that pretty well, but you were on mute when we didn't get a chance to hear your thoughts about which strategy to lean towards.
Yeah, I apologize about that. I don't know what was happening, but we go to a shorter duration of dual antiplatelet therapy and go to aspirin alone, or do we actually keep the P2Y12 therapy online for as long as possible and drop the aspirin? So I believe we're going to move towards the latter. I believe that we're going to gain more and more evidence that combining aspirin with a P2Y12 inhibitor perhaps is not the best possible way to, that there is no reason to do that. In fact, we have seen from the early data of Capri that when you compare in over 13,000 patients in Capri, if I can bring you back to 20 years ago, when Capri was done, when aspirin was compared to clopidogrel, there was more bleeding actually with aspirin than it was with clopidogrel. And the ischemic benefit was similar, or if not better, for clopidogrel. So why we have gone to this dual antiplatelet therapy, probably because in the early stent days, if you remember, when we combined aspirin and clopidogrel, or aspirin and ticlopidine in the STARS study, compared to aspirin alone versus aspirin plus Coumadin, we reduced stent thrombosis at 1 month by the orders of like unbelievable orders. It was one of the best trials. Marty Leon was the PI, and he presented that in the New England Journal of Medicine. And that's why we went to this aspirin P2Y12 combination. But at the moment, we've never, ever tested stents alone with a P2Y12 inhibitor. And the question of a short duration with aspirin up front and then stopping. And in some cases, you know, in an acute coronary syndrome, I really want them to receive the potent agent for as long as possible. And the reason why we don't do it is because we're worried about bleeding. Well, then leave that agent on board and drop the aspirin. And we've shown that now. The TICA study showed this. We showed it in the Twilight ACS sub-study published in the European Heart Journal. I think more and more evidence, and now we're doing a patient-based meta-analysis looking at this, more and more we're going to see that we're going to go to this P2Y12 monotherapy when push comes to shove. I think that's the way we're going to go. Cost is the big issue, of course.
Yeah.
Right. Well, thank you. This has been a great discussion. We want to thank Dr. Mehran and Dr. Sobhi for a really great presentation. And I want to thank Dr. Shahab, my co-moderator. And stay tuned for our next session, which will be addressing heart failure.
Thank you. Thank you.
Hello, good evening, everybody. I'm Dr. Mahmoud Hassanin. I'm professor of cardiology at Alexandria University. I'm pleased to introduce Professor Magdi Abdelhamid. Dr. Magdi Abdelhamid is professor of cardiology at Cairo University. He is the current president of the Egyptian Working Group of Heart Failure, and he is the immediate past president of the Egyptian Society of Cardiology. Dr. Magdi Abdelhamid is also co-author of the Egyptian Registry of Heart Failure publication. He is a very active researcher, and he's a lecturer in most of the local and many international meetings. And I'm excited to listen to his presentation, Contemporary Management of Heart Failure. Please, Dr. Magdi.
Good evening, everyone. Thank you very much, Professor Mahmoud Hassanin, for this kind introduction. I'd like to welcome Professor Funaro for joining us today. Professor Depti, thank you very much for this great sessions and webinars. It's a good idea to have these webinars during this year. Unfortunately, we were not able to host the ACC Middle East in Egypt due to the pandemic, and we are looking for ACC Middle East next year. So my assignment today is contemporary management of heart failure with a reduced ejection fraction. In a couple of minutes, I'm going to talk what we are going to manage patients with heart failure according to the European and American guidelines. This is my declaration of interest. I have nothing to declare. And we know that heart failure is a complex syndrome, a disease which is associated with high incidence of mortality and recurrent hospitalization. And according to this slide, we know that the pathophysiology of heart failure starts after myocardial damage with activation of the neurohormonal system, activation of the sympathetic system, renin-angiotensin system, endothelin system. And all these compensatory mechanisms initially are beneficial, but will later on lead to salt and water retention with increased preload and the ventricular filling pressure, which are responsible for symptoms and signs of congestion. Peripheral vasoconstriction with increased systemic vascular resistance due to increased afterload lead to low stroke volume and follow cardiac output. So patients are complaining of symptoms of congestion and or symptoms of low cardiac output. And we know the classification of heart failure either is reduced ejection fraction, symptoms and signs of heart failure with an ejection fraction less than 40%, mid-range ejection fraction 40 to 49, in addition to symptoms and signs of heart failure with high level of natriuretic peptides, and additional criteria of diastolic dysfunction, while HFpEF patients who have an ejection fraction of 50%. We know that the treatment of heart failure strategy are aiming to improve symptoms and quality of life. But most importantly is to reduce hospitalization, which is the main concern for patients with heart failure, repeated hospitalization, in addition to improve survival for patients with heart failure. So we have many targets which can be tackled to improve the neurohormonal status, renin-angiotensin-aldosterone system by the use of ACE inhibitor, ARBs, ARNI, or aldosterone antagonist. Sympathetic system can be abolished by the use of beta blockers, natriuretic peptides which are beneficial, so preservation of natriuretic peptides through the use of ARNI. High heart rate, which is deleterious in patients with heart failure, can be managed with beta blocker and ivabradine. And for American plaque patients, we can use the combination of hydralazine isorbide 9A3 combination. And the sudden death, which is common in heart failure patients, 50% of patients die suddenly due to lethal ventricular arrhythmias. And this can be managed by implantation of an ICD. And in patients who have an electrical and or ventricular dysynchrony, those patients are candidates for cardiac resynchronization. And we know that congestion can be managed with the use of flexible diuretic therapy and to improve the exercise capacity and rehabilitation. This is very important for patients with heart failure. So regarding the use of diuretics, which are symptomatic treatment, we have to consider the deleterious effects of excessive diuresis in the form of activation of the renin-angiotensin-aldosterone system and sympathetic system. So we have to use a flexible diuretic therapy to maintain evolemia. Diuretics have no impact on mortality. Patients who develop diuretic resistance, most commonly caused by poor oral bioavailability, and this carry a poor outcome in advanced heart failure. Thiazides and the aldosterone antagonist should be given before loop diuretics, and the sodium restriction is mandatory. Regarding the treatment which improves survival for patients with heart failure, according to the guidelines, we know that ACE inhibitor, beta blocker, MRA are considered a class 1A drugs which decrease the mortality and they reduce the risk of heart failure hospitalization. And this was based on many landmark trials, either starting by ACE inhibitor like Solvit trial in Alapril, which was associated with a reduction in mortality of 16%, the use of ARBs reduction in hospitalization mainly, and beta blockers, which decrease mortality by 34% in CBS2, Merit Heart Failure, Copernicus trial, and the MRA antagonists like spironolactone in RELS trial, which was associated with reduction in mortality of 30%. So all these drugs are considered a class 1A recommendation. When we are using ACE inhibitor, we give you ACE inhibitor because it improves symptoms, clinical status, and exercise capacity, improve cardiac function, decrease hospitalization, prolong survival, and reduce vascular events. And in the daily practice, we have to consider it for patients with EF less than 40% and all NEHA classes. And we have to use target doses, not using many doses. We have to use the doses which are used in clinical trials. Patients who have a cardiorenal limitations is associated with poor prognosis and expected to see an increased creatinine up to 30% after initiation of ACE inhibitor and up to 0.5 milligram per deciliter. Unfortunately, most studies excluded patients who have serum creatinine more than 2.5. The rationale for using beta blockers is due to increased sympathetic nervous system activity in heart failure, the deleterious effects of catecholamine stimulation because it increased myocardial oxygen demand and ischemia, it increased oxidative stress, has a deleterious effect for remodeling, and it lowered the threshold for ventricular arrhythmias. Also, it has a toxic effect of the norepinephrine, myocyte necrosis, and apoptosis, and down regulation of beta-1 receptors in heart failure. So when we are using beta blockers, we are expecting to see upregulation of beta receptors, decreased myocardial oxygen requirements, antiarrhythmic effect, improved myocardial relaxation, decreased heart rate, protection against the high level of catecholamines, corrected the overactivated RAS system, and reduction acute coronary syndrome. And this slide shows the trials for the use of beta blockers, CBS2, Merit, heart failure, Copernicus, and all these trials were associated with significant reduction in mortality. So beta blockers in the daily practice should be used in symptomatic or asymptomatic heart failure with an ejection fraction less than 40%. And we have to use drugs which are used in the clinical trials, achieving the target dose by titration of the drugs every 2 weeks, guided by clinical evaluation, heart rate, and blood pressure. And the most trials stop titration when heart rate is in the low range of less than 60 or systolic blood pressure less than 90 millimeter mercury. And we have to adjust the doses according to symptoms, blood pressure. And in acute decompensated heart failure, usually you can treat without change beta blocker doses, except in patients who have evidence of hypoperfusion and very low blood pressure. Regarding aldosterone antagonists, should be considered in most patients with heart failure with an EF less than 40%. We have to keep eyes on serum potassium and creatinine, and you have to stop it and contraindicate it if the potassium level more than 5, advanced renal insufficiency with creatinine more than 2.5, very cautiously be taken in elderly diabetic patients due to the risk of hyperkalemia, and to consider the use of eplerenone post-MI or patients who have side effects like gynecomastia in patients taking spironolactone. Now the sacubitril valsartan or ARNI, a combination of valsartan and sacubitril, and the rationale for using this drug is to inhibit neprilysin, which is responsible for degradation of the endogenous vasoactive peptides like ANP, PNP, CNP, bradykinin, substance P. All these vasoactive peptides have a beneficial effect in the form of vasodilation, decreased blood pressure, decreased sympathetic tone, decreased aldosterone fibrosis, hypertrophy, natriuresis, diuresis. At the same time, neprilysin is responsible for degradation of angiotensin II. So we have to use a drug which blocks AT1 receptors. Valsartan can do that. So we are avoiding the harmful effects of excess angiotensin II at the level of AT1 receptors, such as vasoconstriction, increased blood pressure, increased sympathetic tone, increased aldosterone fibrosis, or hypertrophy. And this is the actual mechanism of the drug. So paradigm heart failure trial, this is the important trial which randomized 8,400 patients starting with enalapril 10 milligram PID, single blind run-in period, then giving sacubitril valsartan for 2 weeks in a dose of 100 milligram PID, titrated after 2 to 4 weeks of 200 milligram PID, which is a target dose, and the randomization either enalapril or sacubitril valsartan. And this study was terminated earlier due to the overwhelming benefit of sacubitril valsartan compared with the cornerstone ACE inhibitor in heart failure in terms of reduction of the primary endpoint, cardiovascular death or heart failure hospitalization. So we can see the significant reduction in the primary endpoint with the use of sacubitril valsartan compared with enalapril, with a very highly statistically significant p-value. The number needed to treat was 21 patients. If we look individually for these endpoints, cardiovascular death decreased by 20% with a statistically significant p-value. Number needed to treat was 32. All-cause mortality decreased significantly, about 16% with a high significant p-value. And the use of sacubitril valsartan was associated with reduction in all-cause death and different modes of death. So all-cause mortality decreased, cardiovascular mortality, sudden death, which represent 50%, and death due to worsening heart failure, which is also responsible for 50% of mortality in patients with heart failure. So according to this favorable data, the guidelines, 2016 EC guidelines, consider the use of sacubitril valsartan as a class 1P recommendation as a replacement for ACE inhibitor to further reduce the risk of hospitalization and the mortality in ambulatory patients with HFrEF who remain symptomatic despite optimal treatment with ACE inhibitor, beta blocker, and MRA. Also, the last guidelines consider the heart rate control is very important. So the new recommendation for IF current inhibitor, ivabradine, which slows the heart rate. So it's a class 2 recommendation to give an ivabradine for patients who have a heart rate more than 70 beats per minute, in spite of giving a maximum tolerated doses of beta blockers, or in patients who are contraindicated for beta blocker therapy. Again, the rationale for lowering heart rate in patients with heart failure is to reduce myocardial oxygen consumption, improve contractile performance, improve diastolic filling, reduce the risk of VF and sudden death, and promote reverse remodeling. So this interesting therapeutic algorithm for heart failure that all patients should be given diuretics as symptomatic treatment to relieve congestion if they have evidence of congestion. Then patients should be given ACE inhibitor and beta blocker up titrated to maximum tolerated doses. If the patient is still symptomatic with an EF less than 35%, MRA should be given. If the patient is still symptomatic and EF less than 35% with heart rate more than 70, then ivabradine class 2A recommendation. If the patient is considered a candidate for CRT with a QRS duration more than 130 milliseconds, this is considered also an indication for CRT. Patients who are giving ACE inhibitor and still symptomatic, early can be given cyclomitry valsartan to decrease mortality. And the patients who are still symptomatic, class 2B recommendation to consider digoxin, combination of hydralazine, isobiodine, nitrate combination, LVAD or heart transplantation for patients who are considered a candidates for this mode of therapy. And don't forget that patients who are given optimal medical treatment more than 3 months and still symptomatic with an ejection fraction less than 35%, we have to consider ICD for primary or secondary prevention, and second prevention for patients who have history of symptomatic VT or VF or resuscitated cardiac arrest. The same recommendations from the ACC expert consensus 2017, all patients with heart failure with a reduced ejection fraction, stage C, should be given ACE inhibitor or ARP and beta blocker with diuretic therapy if they have evidence of congestion. And for patients who are still symptomatic, mineralocorticoid receptor antagonists should be given if the serum potassium less than 5, function class 2 to 4. ARNI can be considered for patients stable in ACE inhibitor, NIA function class 2-4, hydralazine isobiodine nitrate combination for persistently symptomatic African American NIA class 2 to 4, and ivabradine for heart rate control. And recently, we have new drugs which are considered a new target for therapy in patients with heart failure. DABA-HF trial for the impact of dapagliflozin, SGLT2 inhibitor, which acts at the proximal convolutive routes to decrease reabsorption of glucose. So dapagliflozin in DABA-HF trial, the hypothesis of the drug that dapagliflozin will be superior to placebo added to standard care in patients with symptomatic chronic heart failure with reduced ejection fraction with and without diabetes. So 4,700 symptomatic patients with an EF less than 40% with high levels of NT-proBNP or hospitalization for heart failure, when added dapagliflozin 10 milligram compared to patients receiving standard of care only, the use of dapagliflozin was associated with significant reduction in the primary endpoint, cardiovascular death or heart failure hospitalization or an urgent heart failure visit, with a highly statistically significant p-value. And interestingly, we can see the benefit of the drug started to appear early. The two curves started earlier after initiation of dapagliflozin. Also, the worsening heart failure event, which is one of the components of the primary endpoint, was highly statistically significant with the use of dapagliflozin, and the same for cardiovascular death. And we can see, interestingly, that the benefit of the drug was proved. Either the patients had diabetes or non-diabetic patients. So dapagliflozin was considered as a new treatment for patients with heart failure, either diabetic or non-diabetic, based on the favorable results of DABA-HF trial in a significant reduction of mortality and heart failure hospitalization. Thank you for your attention.
Okay, thank you, Professor Magdi, for your comprehensive presentation. Well, I have a question for the panelists about heart failure with mid-range ejection fraction. The question is that should we keep this term in the coming guidelines, heart failure guidelines? I'm posing this question because new analysis of all trials have shown that patients with mid-range ejection fraction behave more like patients with reduced ejection fraction. They benefit from the same therapies. And remember that patients with heart failure with reduced ejection fraction of non-ischemic etiology may improve their ejection fraction and move to the category of heart failure with mid-range ejection fraction. I would like to hear the opinions of the panels. Dr. Iktaporia, you hear me?
Yeah. I can hear you, but I'll let Dr. Magdi answer that first.
Okay.
Okay.
It's a difficult question, I know.
For me, I think the new guidelines will not consider a mid-range ejection fraction because now we have also heart failure with recovered ejection fraction. So as you said, Dr. Mahmoud, those patients, we don't have a lot of data in the literature about the mid-range, but most of those patients with developed myocardial infarction, ischemic etiology, and the same treatment like patients with heart failure with reduced ejection fraction. So maybe the new guidelines will consider heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, which is a very common, representing more than 50% nowadays. And it is a heterogeneous disease complex associated with a lot of comorbidities. Heart failure with recovered ejection fraction also is a new entity. Because heart failure with mid-range ejection fraction, those patients may be patients with heart failure with preserved ejection fraction, and it is deteriorated to be 40, 49 instead of more than 50. Or maybe patients who have a very low ejection fraction and they improve to be an ejection fraction 40, 49. So it is a gray zone between, and still we need a new classification based on ejection fraction.
Dr. Fonaro.
I think it'll be very interesting to see how it evolves. But what has been so remarkable is for patients with EFs above 40%, we've yet to have a therapy reduce cardiovascular mortality. We have had a number of therapies tried, including ACE inhibitor and ARBs, and in distinction to those with heart failure with reduced EF, there has not been a reduction in CV or all-cause mortality. The same thing with aldosterone antagonists. Beta blockers have not been well studied, but obviously there's coronary disease and other effects. And even what's notable with sacubitril valsartan, although it wasn't studied with EFs 41 to 44, 45 and above, yet in Paragon, no reduction in cardiovascular or all-cause mortality. Yes, a little reduction in heart failure hospitalization. So I still think that mid-range ejection fraction, when it's EF between 41 and 49, there is likely a mixed population. And I think blending them in to heart failure reduced EF can be misleading to the clinician if they believe using the therapies that are so remarkably beneficial in heart failure reduced EF that they're going to get that same benefit. Now, that does not mean there's not a subgroup there that may very well benefit from these meds. We just need to be smarter to figure out what are those additional markers beyond EF that will help us identify which of those patients will benefit from the meds. But I do want to emphasize that heart failure where the EF started off below 40 and now improves, those patients, whether you call them improved, recovered, remission, they need to absolutely continue on the heart failure reduced ejection fraction medications and not be misclassified as heart failure mid-range or heart failure preserved EF, because they most certainly are not. And we see in TREAD-HF trial that in fact withdrawal of guideline-directed medical therapy causes pretty immediate harm to those patients.
Dr. Valika, what are your thoughts?
It's a great question, and I think the natural history of mid-range ejection fraction, we don't completely understand it, like Dr. Fonaro said. And I see a lot of chemotherapy-induced cardiomyopathy also in my clinic, where the EF comes to the mid 40s, and it recovers. And my concern is, I think now that we have sorted out the big picture, that is HFrEF and HFpEF, there are some gray zones. For example, if the starting ejection fraction was 60% and is now 50 to 55%, is that normal systolic heart failure, or is it diastolic heart failure, or is it mid-range ejection fraction? We need to tease all this out. And as you all know, that peripartum cardiomyopathy and alcoholic cardiomyopathy have a much better prognosis compared to HIV cardiomyopathy. So I think the future will be more, instead of one-size-fits-all kind of approach, it'll be more personalized approach to how we manage these patients.
Okay.
Another question?
Yes, of course.
We know, thank you very much, Dr. Magdi. Your talk is contemporary treatment. I mean, that this is a new terminology for the contemporary. We just discussed this with Dipti. You have a patient heart failure. The main problem is the quality of life and recurrent rehospitalizations. And you have symptoms and you have an ejection fraction. And that's cool. So you depend on quality of life or ejection fraction in this patient. If you are in need to prevent recurrent, you have weapons now, new weapons. Are you starting with all your weapons, or you have to make it in a systematic way? Just diuretics, beta blockers, HRBs, and then go for SGLT2 if not responding. You wait for this because you all know that quality of life is important. Recurrent resuscitation is important.
Yes, regarding the symptoms, as we said, the diuretics, the drugs which relieve symptoms of congestion, because patients is complaining of shortness of breath. So diuretics can relieve the congestion and can improve shortness of breath. But we are looking for the drugs which decrease hospitalization, which is the main concern, which represent a burden for the healthcare costs, recurrent hospitalization, and of course, mortality. So ACE inhibitor, beta blocker, MRA, sacubitril, valsartan, the drugs which prove in the clinical trials to decrease hospitalization and improve survival. So I will start with ACE inhibitor, beta blocker. If there is no contraindication to add MRA, if the patient is still symptomatic, I will add MRA. If the patient is still symptomatic, I will consider to replace ACE inhibitor with sacubitril, valsartan. Sacubitril, valsartan cannot be given for function +1. It's function +2 to 4, according to the paradigm study. So systematic approach for those patients, according to the guidelines, this is the ideal management strategy for patients with heart failure.
I guess that brings up a really good question. Can I, Greg, so do you do a stepwise approach, or do you just say that sacubitril valsartan works, so should you just be going with that from the beginning? I think that's Mohammed's point, right, Mohammed?
Yeah.
Saying, why are we waiting?
Yeah.
Why are we
you are asking for giving sacubitril, valsartan for a naive patient, not for ACE.
No. I'm speaking about the two drugs which change the words. The ARNI and SGLT2. Nowadays, these are the most important drugs. So why to wait to tell you from? Forget about the cost. If the cost is okay, insure the body, because if you cost benefit, make it by number needed to treat and go to the observation. If you make this, you save the life, the patient quality of life is improved. So how can you make it?
Let me make it even easier. We can consider cost, and you still come out ahead starting sacubitril valsartan in a hospitalized patient. We just published in JAMA Cardiology the economic analysis and the large effects on hospitalization reduction early on, meaning delaying ACE inhibitor for 8 weeks ends up economically costing more because of those preventable hospitalizations. So Mohammed, I think your question is really insightful. And now that we have additional evidence from quality of life in real world, as well as the trials, and that early reduction greater with sacubitril valsartan than with ACE inhibitor or ARBs. With the early benefit seen with SGLT2 inhibitors, we can really make a case of trying to get these 4 core medications started as soon as possible, even during that initial hospitalization in symptomatic patients with heart failure with reduced EF. It's really great. This delayed therapy just leads us having early events that could have been prevented and worse health status that could have been improved early on.
But I think in the near future, precision medicine, which drug for which patient will be the strategy for management, because polypharmacy in management of heart failure patients also is an important concern and entity. So we are giving drugs according to the patient.
What do you think, Dr. Balaga?
Yeah, and I'm going to be discussing this in my talk.
Okay, so maybe we should go to your talk. I'll let Greg introduce you.
Yeah, so I'm really delighted to introduce Dr. Balaga. He is a professor of cardiology and medicine at The Ohio State, very well published and knowledgeable in heart failure, played a major role in the Heart Failure Clinics Journal, and delighted to have him present on the emerging therapies for heart failure.
Thank you. And I want to thank Dr. Dipti Pikoria, Dr. Sobi, and Dr. Magdi for inviting me to participate today, and Dr. Fonero, Dr. Hasnain, and other participants. I look forward to giving this talk because it's a nice continuum from the terrific talk Dr. Magdi gave a few minutes ago. And let me share my slides with you all. So my disclosures are: I served as the consulting editor for heart failure clinics. Can you see my slides?
No, we can't see your slides yet.
No. I think you have to go to Zoom, take your slides from the Zoom itself, and then share it. Would share it? Yes. Okay.
Yes, there we go.
Okay, perfect.
Okay.
So my disclosures are: I served as the consulting editor for Heart Failure Clinics of North America with Jim Young several years ago, and I'm the CME editor for flagship journal JACC of the American College of Cardiology. So Dr. Magdi Hamid gave a very elegant talk on the state of the art as of today. But today I'm going to, by the end of this talk today, hopefully all the participants will understand that the 4 pillars for therapy for HFrEF is going to be ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. So when you go back to MERIT's CHF, which came back in 1999, and you look at the mode of death, depending on whether it's NYHA class 2, class 3, or class 4, sudden death is why patients with class 2 and class 3 are more likely to die, while in class 4, it's going to be more decompensated heart failure. So whenever we talk about survival, we need to sort of keep these things in mind, that survival is because we save lives by reducing the burden of sudden death and systolic heart failure. So as Dr. Magdi said in his previous talk, if you look at this slide, the decrease in mortality with the ACE inhibitor or an angiotensin receptor blocker is modest. It's 10 to 12%. And as much as it's state of the art today, one would argue, as newer and newer therapies are emerging, that the four horsemen are going to be beta blockers, MRAs. Because look at the benefit we get with mineralocorticoid receptor antagonists, 30 to 35%, 30% with mineralocorticoid receptor antagonists and beta blockers. So the biggest bang for your buck, so as to speak, is with beta blockers and mineralocorticoid receptor antagonists. And if you look at neprilysin inhibitor, compared to ACE inhibitors and ARBs, there's a doubling of survival with ARNI. And yes, cost is there, but as Dr. Fonero said, there's an elegant cost-benefit analysis which looks at rehospitalizations, length of stay, the amount of money you save by using the newer medications far outweighs the upfront cost of the medications as it's calculated today. And the other important thing with ARNIs is if you look at ACE inhibitors and beta blockers and you look back and see the survival curves opening up, it usually opens up after 6 months of randomization. But with ARNIs, you see the benefit as early as 40 days. So these drugs are really powerful, highly effective drugs. The slide is a bit fuzzy, but it shows the impression at around 2 months. The curves nicely separate out even as early as the end of the first month. So we need to keep that in mind too. We want to get the best return from the therapies we use in our patients. So in the paradigm of heart failure, this slide, if you look at it right at the top, you see that the reduction with ARNIs, 20% reduction in sudden cardiac death. It's like an ICD. And 21% reduction in heart failure death. So we need to keep this in mind whenever we look at heart failure medications, is how is it reducing the mortality? And because that will allow us to better develop our drugs and even prescribe to our patients. So what happened is that in the late 2000s, the FDA mandated that the anti-diabetic medications should not make cardiovascular risk worse. And so the endocrinologists started looking at cardiovascular risk in anti-diabetic drugs. And in 2015, epagliflozin was studied in the EMPA-REG study, and they found that the benefit that it improved cardiovascular risk, and it was driven by reductions in heart failure hospitalizations and cardiovascular mortality, not by reducing MIs or strokes. And so that was the first wake-up call that these new class of drugs can be beneficial in heart failure patients. And in fact, at that time, in 2015, no one really believed it. They said, oh, it's one study, who knows, you know what I mean? But subsequently, we had the CANVAS study, which looked at canagliflozin in type 2 diabetics again. And again, if you look at the study, canagliflozin was much better in reducing death from hospitalization for heart failure and death from cardiovascular causes. It also showed there was some improvement in renal function too. And as you all know, as heart failure cardiologists, we actually deal with cardiorenal failure. About 40% of our patients have diabetes, and many of them have renal dysfunction. So this was the second study which showed that the SGLT2 inhibitors may benefit our heart failure patients. And then Steve Wibbert from the TIMI group and at the Brigham studied the declared TIMI 58 study, which also showed that indicated that dapagliflozin is beneficial from a heart failure perspective in diabetics. So this is what prompted John McMurray to design the DAPA heart failure trial, where they looked at nearly 4,500 patients with placebo and one dose of dapagliflozin, 10 milligrams. So there's no up titration. You don't have to bring the patient in, keep up titrating the medication. It was one dose. And most of the patients were NYHA class 2 to class 3, and the average ejection fraction was about 30%, and the average GFR was about 66%, 41% at CKD, and guess what? 55% did not have diabetes in this study. And again, as Dr. Magdi discussed, there was this huge benefit in the DAPA heart failure in reducing the primary composite outcome of worsening heart failure, which was hospitalization or urgent visit resulting in IV therapy for heart failure or cardiovascular death in patients with heart failure, and HFrEF with or without type 2 diabetes. That was the main message. It was beneficial. And as you'll see, dapagliflozin was better in all patients, whether they had diabetes or whether they didn't have diabetes. So benefits were seen with or without diabetes is once a day therapy, single dose, no need for titration, no episodes of hypoglycemia or diabetic ketoacidosis, because there were concerns from the canvas and declared to me that this may be an issue, negligible incidence of amputations, and the number needed to treat was 21. Of course, we need more validation. We are awaiting EMPEROR-reduced study, and we need more data about the resolution of mechanism. If, in fact, there were some nice, elegant reviews by Dr. Braunwald on SGLT2 inhibition, a two-part series in JACC about the mechanism, and the mechanism is really elegant. By that, I really mean is we don't know what the real mechanism is, but there are several postulated mechanisms. So this is a slide which I borrowed from Dr. Fonero, which shows when you look at number needed to treat for mortality, ARNIs and SGLT inhibitors tools are even more effective, are as effective in reducing mortality. Of course, it was 9 for beta blockers and aldosterone antagonists, and 15 and 22. And you can see that the relative reduction of mortality with SGLT2 is 17%. And this is much better shown in this slide when you look at the relative risk, which again, I want to thank Dr. Fonero for this slide. So a 2-year mortality with no medications, the take home today is 35%. When you added ACE or ARB, then the 2-year mortality was 27%. With when you added beta blockers, 18%. And then we added aldosterone antagonists, it was 13%. And ARNIs is down to 10%. And so, and with SGLT2 inhibitors, also it's down by another 17%. So if you use quadruple therapy, the big four, like I said in my very first slide, there's a 72.9% relative risk reduction. And the absolute risk reduction was 25.5%. And the number needed to treat was 3.9. So just think about it. Such a small number needed to treat. And just for those who are not aware, the smaller the number for number needed to treat, the better the drug is. And so if you compare to ACE or ARB or beta blockers, like Dr. Magdi said in his previous talk, and switch to ARNI, switch to an aldosterone receptor antagonist, and start SGLT2, you extend the patient's life in HFrEF by 6 years. I mean, that's a substantial improvement in the duration of life. And in this final table, you will see that the potential lives per year with an ACE and ARB is about 6,500. When you replace it with an ARNI, 28,000 patients. With beta blockers, it's about 12,000 patients. An aldosterone antagonist is 21,000 patients. And with SGLT2 inhibitors, it's 34,000 patients. In fact, Dr. Fonro had a very elegant JAMA article a couple of months ago, which is a must read, where they looked at all the systolic heart failure patients in the US. And after all exclusions, including renal dysfunction, they came down to from 6.1 patients, 6.1 million patients. They found 2.1 million patients eligible. So you can see the substantial benefit of these four horsemen. And so yes, this is emerging, but hopefully this will be. It's a bit like pravastatin and atorvastatin. The ACE inhibitors are going to be like pravastatin, I think. And the big four in the horizon is ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And Dr. Fonero has done this very elegant cost effectiveness. And when you look at the quality of life and cost effectiveness, even though these medications with current costs seem to be expensive upfront, but when you look at hospitalizations, mortality, they're far more cost effective. And then the last thing, emerging heart failure, which I'm going to just speak for a minute, is the new drug, the Victoria study, which is one study which showed in patients with high-risk heart failure, the incidence of mortality from cardiovascular cause or hospitalization for heart failure were much lower with the soluble guanylate cyclase stimulator, vericiguat. And this is only one study, but something to keep in mind. And then the future, I think it's going to be microRNAs, drugs which affect the contractile process, gene therapy, cell therapy, antifibrotic therapy. And before I finish off, I co-authored a white paper with Bill Deck and Jagat Narula on managing heart failure in lower and middle income countries, which I thought our listeners may be interested. If they're interested, if they send me an email, I'll be happy to send them a copy of this white paper. Full disclosures, I got some of my slides from my books and from Dr. Fodero. Thank you.
Thank you for that excellent presentation. I think we can open it up to the panelists for questions now. I do see some that have come in, so I'll just start off one for our panelists, which is, should we consider the SGLT2 inhibitors a class effect or consider it just unique to dapagliflozin for patients with heart failure with reduced ejection fraction? What do you think?
Me?
Yeah, Richard.
Yeah. I think at this point I'm more inclined to go with dapagliflozin just because it's not only the benefit but also the side effect profile is much more well documented compared to the others. The others did show an uptick, but those studies were not necessarily designed at HFrEF patients. And if you want to go by the evidence, I think I'm more inclined to follow the dapagliflozin at this point.
Magni, what do you think?
I think based on the data which are available from many trials for SGLT2 inhibitors, although DABA for heart failure, either mortality benefit, decreased hospitalization, but also we have other drugs than DABA, which has a cardio and renoprotective effect. So all these class have the same mechanism of action, either renoprotective, hemodynamic effect, metabolic effect. So I think it's a class effect, but due to the large study focusing on heart failure in DABA-HF, so we have the evidence now that DABA is different from others.
Great. Well, do you have any thoughts?
Well, I think it is a class effect. It's only that canagliflozin had some worrisome side effects in the CANVAS program. But I think regarding the cardioprotective and nephroprotective effects, this is a class effect.
But I'd like to add that for dapagliflozin, because recently there was a concern for ketoacidosis with the use of dapagliflozin, so it should not be given for critically ill patients, type 1 diabetes, patients who have recurrent UTI, because genitourinary tract infections is common also. So we have to consider this drug for a specific patients who will get the benefit, because some side effects could be happen, especially in elderly population, patients who are at high risk for hypoglycemia, etc., etc.
Yeah, I think, Mandy, you raise a really critical point. All of these trials have excluded patients with type 1 diabetes, and they are the few studies that were looking at SGLT2 inhibitors in type 1 diabetes. There was a much higher rate of diabetic ketoacidosis. So these findings should certainly not be generalized to those patients. We do have some small pilot data starting at in-hospital and acutely decompensated heart failure patients that appeared to be safe, and even within 30 to 60 days, seeing clinical event reduction. But those were all patients type 2 diabetes. What was so remarkable in DAPA-HF in the patients without type 2 diabetes, really the side effect profile was literally identical with placebo, not a single DKA, none of these urinary infections. So appears to be particularly well tolerated. And we will see the DAPA chronic kidney disease trial present at the ESC meetings virtually next week, and look forward to having that data available to us, as well as is coming up shortly, reduced heart failure trial. Another question has come in, which is about rabidine. Does that have an impact on mortality? Why was it sort of left off the core pillar list?
Which one?
Rabidine.
Yeah, rabidine. Yeah, I think the data, it's somehow never reached mainstream, at least here in the, and the data was not that robust for it to be one of the 4 pillars. And I think, I don't know who makes ivabradine, but I think they didn't make a big investment to definitely show that it is efficacious.
SHIFT trial, which showed the benefit of ivabradine, the primary endpoint, cardiovascular death and heart failure hospitalization, was driven mainly by a reduction in heart failure hospitalization of 18%. It's not a mortality reduction.
Well, I have a question to Dr. Baliga.
Yeah.
With the use of the big 4, as you said, RNA beta blockers, MRAs, and sodium glucose transport inhibitors, do you think that we have to revise the guidelines for ICD implantation, CRT implantation?
Yeah, so that's a great question. And I was thinking whether anyone will ask me the question, because we still don't know what the mechanism of these SGLT reduction death. They didn't talk about sudden death at all. I Googled like till I was blue in the face, and I couldn't find anything. And how it's impacting, because if you go back and look at the data, it talks about heart failure death. It doesn't talk about sudden death. And if you know that a lot of the mortality benefit comes from sudden death. So I'm waiting for, I actually went to Jack yesterday and looked at, not the original New England article, but the second articles, which usually come from these big trials, to see whether they have shown any mortality benefit from sudden death. And so, yes, I won't be surprised if we have to change the guidelines down the future. Even with ARNIs, there's so much sudden death improvement, you wonder whether you have to put an ICD in everybody, to be honest,
Yeah. Okay.
Greg, what are your thoughts?
In a certain sense, that's, a rationale for starting early with these meds at that 3-month mark. You may have had an improvement in EF where it's now above 35% and can defer. Certainly the Danish trial kind of opened that door, but since 58% of those patients had cardiac resynchronization, it's a little hard to know if we can generalize, but it does open that door to, do we need to retest ICDs on now what is background pillar of gold standard guideline-directed medical therapy as to whether sudden death has fallen so low that there won't be a benefit of these expensive ICDs, and we can invest that money in the medications.
Okay.
Can I ask a question? Is there a diuretic dose adjustment when you put those, say something like DAPA on? Because, you would think it has a diuretic effect, and so just for renal protection. And is that standard? Because I don't think the articles really talk about that.
Yeah, so I think in the DAPA heart failure, as Greg said, compared to placebo, the side effect profile was almost identical. So, but if you look at the other two trials, there was a suggestion that caused a lot of diuresis. And the nephrologists seem to be talking about diuresis too in the setting of, not nephrologists, endocrinologists, in the setting of diabetes. And I won't be surprised initially when people are trying to be cautious. I remember when I was a fellow way back in 98, when we used ACE inhibitors, we used to admit them for first dose hypotension just to start ACE inhibitors, and now we do it routinely. So I won't be surprised initially that many of us may want to start it as an inpatient, especially in patients who are dry at baseline, as opposed to someone who's wet at baseline. We may be able to get away with it. even as an outpatient. So, yeah, so in our institution, we have been prescribing, I was just talking to our pharmacist, about 2 or 3 a week, because we still have to get approval from the insurance companies. It's not still mainstream. And we are learning as we go along the way.
So, Dipti, your question was great and was anticipated by the DAPP-AHF investigators. They just published on looking about changes in diuretic dosing as a function of treatment, and there was no empiric adjustment done, so that's not necessary. But actually, over time, most patients did not require an adjustment of their dose of diuretics, and as was referred to, was well tolerated. So you saw similar efficacy regardless of background diuretics. Most patients didn't require adjustments, but when there were adjustments, about 10-15% of patients did require their diuretic dose to go down over time in the dapagliflozin versus placebo group. So monitoring of volume status is important, and same thing with sacubitril valsartan. So you may need to fine-tune their dose, but there's no changes needed in their diabetes medication or their diuretic or background heart failure therapy when you're starting an SGLT2 inhibitor.
And I think the patients in the hospital, I can see that, but I'm thinking about the patients that come back to your office and they've been on a heart failure regimen. And now you have this data and you think, well, the EF has been stable. Let's just add this on. And they've been on it. Those are the people that I'm thinking that may need some adjustment.
But that was the DAPP-AHF population. They were all outpatients. It wasn't started inpatient. So, but if you have a patient clinically where they're on the drier side and you're concerned, you can make that type of adjustment if you feel it's necessary. But at least in the trial, which was in chronic stable outpatients, there was not an empiric protocol-driven adjustment to either the diabetes medications or their loop diuretics.
Can I ask a question regarding the follow-up of the patients of heart failure? I mean that the symptoms is the crucial point of heart failure, but the biomarker and the echo, do you think that we still need a global longitudinal strain for the echo for those patients and pro-PMP for follow-up of the patient, or just depending about the symptom? The symptom improve, don't look for any echo or don't look for any biomarker, because sometimes the dose adjustment. This is the first question. The second question regarding SGLT2. We have 2 drugs now with two different trials. Do you think it's a class effect, or it is depending on which one is the preferred? I know that
we answered this question.
We answered the question about the class effect.
I see.
Yeah,
because already next week we have a trial by the EMPA, the new trial, the EMPA, the next week in European Society of Cardiology.
Okay. The Emperor trial, Emperor.
Yeah. So answer that first question regarding the follow-up of the patient heart failure.
We have, from the literature, we have a controversy regarding follow-up of the patients, either clinically guided or PNP guided. Some data are in favor to be NT-proBNP guided, because this allows the use of guideline-directed medical therapy proper in the target doses. And there was a benefit in terms of mainly reduction in hospitalization, not mortality. But this was different in elderly versus young. However, still the guidelines did not recommend a routine follow-up guided by NT-proBNP, and usually in the daily practice, we are following our patients clinically guided. But I'd like to add that NT-proBNP is of great help, especially before discharge from hospital, because to handle the medications before discharge, because the critical time for heart failure patients, the first 30 days, in which the mortality and the rehospitalizations are very high. So NT-proBNP before hospital discharge can allow the use of guideline-directed medical therapy, and especially now, we can give the sacubitril valsartan according to Pioneer HF trial before discharge. We have to start beta blocker in hospital and titrating the dose gradually. So this is of great value in hospitalized patients to estimate the NT-proBNP.
Okay, thank you.
Yeah, and I'll just add, The biomarkers are very helpful for prognosis, but using them as a guide for what therapy you'll start or to titrate that therapy has really not worked out. The large multi-center guided trial really failed to demonstrate that benefit. What we really need to do is follow the guidelines and the evidence of trials, which is institute the therapies and then up-titrate as well tolerated to target doses. And as we do that, we get these remarkable improvement in symptoms. We get patients staying out of the hospital, the extension of survival, but also, fortunately, the prognostic biomarkers improve, ventricular function improves. There was that question about global longitudinal strain, and that is very intriguing as to whether it will give us additional information up and beyond ejection fraction that may be more actionable, but unfortunately hasn't been integrated into the clinical trials yet. And we don't have enough data to really know how it should guide us, but it needs some active investigation.
I think GLS is of value in cardio-oncology for early detection of subclinical LV dysfunction. It's of great help. It can identify early, in addition to NT-proBNP, both GLS and NT-proBNP can identify those patients because this allowed the use of ACE inhibitor and beta blocker early, which was associated with a benefit in terms of reduction in mortality.
Yeah, we are using GLS in chemotherapy-induced cardiomyopathy. If the starting ejection fraction was 60% and it comes down to 55% and the GLS is also trending down, that's when we are more inclined to start therapy. And of course, this is all based on empiric evidence. There's no hard data, but it's something which we have embraced it to manage our patients, sort of nip it in the bud, so to speak. I think the bigger concern is in 2014, Paradigm Heart Failure showed benefits of ARNIs. And in 2017, it was estimated fewer than 15% of HFrEF patients were getting it. And Jim Fang, in a very elegant editorial in the New England Journal of Medicine, said, will we be waiting until 2022 before SGLT inhibitors were used in 15% of the patients? I think the impact is so huge. We really need to sort of pursue this with kind of an evangelist kind of approach and start considering this in our patients.
Can I have a questions to the experts heart failure here? You know, the prevention I think is highly important, and we have in diabetes in our region is so highly prevalent. We have around worldwide about 400 million of diabetic and 228 million of heart failure. So patient with diabetes, and we know the SGLT2, the role of that of prevention. And I don't see that amount of collaboration between our cardiologists and our endocrinologists and you already registry in US shown that the use of SGLT2 5%. So how we can improve this? And I mean, this kind of education going on, but we don't see the impact.
Yeah, well, I'll just start. I think that's a phenomenal question to ask. Prevention of heart failure should be on everybody's radar screen. For the patient with type 2 diabetes, their greatest risk actually is not having an MI. They're going to be 3 to 5 times more likely to die in the next 5 years if they develop new onset heart failure. And we can dramatically reduce that risk with SGLT2 inhibitors and reduce their cardiovascular mortality. And that's been shown in so many of these trials. Fortunately, the guidelines have been updated, but as you say, the actual practicing clinician that's seen patients with type 2 diabetes have not necessarily adopted these drugs or an aggressive approach for prevention of heart failure. So I think we all need to be collaborating together. And this will include also the nephrologists who have really had very few therapies that can block progression of chronic kidney disease. It was really ACE inhibitor and ARBs for the last 2 decades. And now this remarkable data for SGLT2 inhibitors that supposedly is going to apply to those even without type 2 diabetes. So this is a phenomenal opportunity to prevent heart failure in the first place, which is the ideal way to treat it.
In fact, I think if endocrinologists prescribe more SGLT2 inhibitors, we may see a lesser burden of heart failure patients in the heart failure clinic. because as Greg has shown in a JAMA article, optimal implementation, we will save 34,000 deaths per year. I mean, that's a big deal.
Okay.
So I think I won't be surprised that if endocrinologists embrace the SGLT2, it'll make a big difference.
Okay, Mahmoud. Okay. خلص.
Okay.
بس you finish.
I think we have to close the session because time is up. I would like to thank the speakers, the panelists, and hope to see you soon in the new webinar. Thank you all. Goodbye.
Thank you. Look forward to seeing you all in Egypt next year.
Yeah, we look for and next month for the next webinar.
Yeah,
sure.
Thank you, Deputy.
يا خبر، سكر ده جالي منين ده؟ اعمل ايه بس واتصرف ازاي؟ وايه دي كمان؟ سهرة ملية؟ ده ايه اللي جابها هنا دي؟ ايه ده؟ انا بتسحب. لا، اسمع كويس يا بدري وشوف لقطات من مستقبلك يمكن تتعلم، وركز في قرارك اللي هيحدد شكل حياتك. ده هيبقى شكل حياتك مع مرض السكر. ما تخافش، افتكر انك ممكن تصلح كل ده دلوقتي قبل ما يفوت الاوان. اول مشكلة هتقابلك اهي. شايف شكل عينيك عامل ازاي؟ يا لطيف، ايه اللي عينيا دي اهم حاجة فيا. وكمان كليتك، شايف شكلها وصل لايه؟ يا ستير يا رب، لا مش كليتي كمان، حتى اطرافك يا بدري. شايف بقى صعب عليك حاجات كتير كنت بتعملها في يومك. ايه انت بتقول ايه؟ يعني قصدك عمري ما هعرف ده غير رجلك اللي ممكن توصل لا قدر الله لكده. لا 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 لا، انا خارج من هنا، مش هقدر اسمع تاني. استنى بس، جه الوقت اللي تشوف فيه حياتك الايجابيه اللي هتبقى حقيقيه لو اتعالجت بدري. اطلع السلم من هنا وشوف دنيتك هتبقى ازاي. يا فرج الله، اخيرا هتحافظ على عينيك ونظرك هيفضل سليم. ايوه يا سيدي، قول كمان. اما كليتك هتفضل زي ما هي سليمه وزي الفل. يا سلام، مفيش احلى من كده. واطرافك كمان، يعني هتعمل كل اللي انت عايزه. ايوه كده، طمنتني. وهتقدر تتمرن براحتك وتجري برجلين سليمه وقويه. انا جاهز ابدا حالا. فعلا ابدا حالا قبل ما يفوت الاوان. ياه، ده المستقبل شايل لي حاجات كتير، ممكن تبقى كويسه او ممكن تبقى صعبه، بس خلاص انا اتعلمت الدرس وعرفت انا محتاج اعمل ايه. مساء الخير يا دكتور، لو سمحت كنت عايز الدواء ده. اصلا انا قررت ابدا بدري واغير حياتي للاحسن، وهو ده الوقت المناسب.
After the two sessions, one about the acute coronary syndrome and the second heart failure, we have now Novar Symposium. Thanks to Novar for sponsoring this first wave of the ACC webinars, regional Middle East webinars. I have the pleasure to introduce my colleague, my friend, Dr. Hisham Salahuddin, Professor of Cardiology and Cath Lab Director in Cairo University. Dr. Hisham is going to speak about an important topic called the essential intervention. And please send the questions to us, me and Professor Mahmoud Hassanin, in order to go and do interaction with Dr. Hisham about your question. Dr. Hisham?
Professor Sobhi, Professor Hassanin, dear colleagues, it's my pleasure to be with you today. I think it will be an interesting session. I'm going to talk about the essential intervention. And just to start, heart failure is not a new issue. It has been killing many people for thousands of years. And these are some interesting data. Actually, there was a famous Italian Egyptologist called Inresto. He discovered in 1904 a mummy for an Egyptian dignitary some 3,500 years ago, who died probably of heart failure. They did DNA analysis, CT scanning, histopathology, and they discovered that probably he died from acute on top of chronic heart failure. And despite that this is an old disease, and the many therapies we have been having for years and years, ACE inhibitors did a great job with reducing mortality. ARB is the same, beta blockers, MRAs, all of them reducing mortality significantly. But in spite of this, 50% of patients diagnosed with heart failure will die within 5 years. Even 51% experienced cardiovascular death with no history of heart failure hospitalization. And 40% of such deaths occurred suddenly, making such a disease, heart failure, actually more serious regarding mortality than most of the cancers. And the problem is not only mortality, but also the hospitalization. We know from different data that heart failure hospitalization is the primary cause for hospitalization in patients aged 65 years or more. And if you are hospitalized once, the chances that you will be re-hospitalized again and again is actually high. 44% of patients will be re-hospitalized at least once. And the problem is not only mortality and hospitalization rates. But actually, heart failure has a very bad impact on the quality of life. Almost 3/4 of patients struggle to perform their daily activities. Almost 2/3 reported symptoms that are consistent with depression. And almost 40% of patients struggle to socialize or engage in daily routine activities with friends or family. And looking at the evolution of heart failure management and the timeline of the different medications that came in, we'll find that back more than 30 years ago, the first ACE inhibitor was actually, after the consensus trial study that was published, actually showed benefit in patients with heart failure. Some years later, the first beta blocker was approved. And in 1999, after the RALS trial, spironolactone was also approved for treatment of heart failure. And then came the first ARB, which was actually, of course, there were many trials using ARBs in heart failure, but one of which was the VALPAP trial, and valsartan and different other ARBs, including losartan and candesartan, became approved later in the treatment of heart failure. But we remained for more than a decade waiting for something new, something that will help our patients to actually go out of the problems they're having regarding mortality, regarding heart failure hospitalization, regarding the bad quality of life, until in 2014, a major trial called the Paradigm Heart Failure Trial was published. The Paradigm Heart Failure Trial, which stands for Prospective Comparison of ARNI with ACE inhibitors to determine impact on global mortality and morbidity in heart failure, was by all means a very large and important trial because it included more than 8,000 patients with chronic heart failure in New York Heart Association classification of actually classes 2 to 4, with left ventricular ejection fraction less than 40% and elevated N-terminal pro-BNP or BNP. And the outcomes of the trial were quite impressive. The primary composite was significantly reduced by 20%. There was a 20% risk reduction of cardiovascular death or first heart failure hospitalization, a 20% risk reduction of sudden cardiac death, a 16% risk reduction of death from any cause, 23% fewer admissions for heart failure, and even intensive care stay was significantly reduced by 18%. Quite impressive result. But what was also very impressive was the impact on the quality of life. Actually, the effect of sacubitril valsartan on quality of life was sustained for 36 months over the same treatment period, Patients treated with enalapril experienced a significant decline in the quality of life, a thing that was actually not seen or actually was maintained, at least in patients who received sacubitril/valsartan. So looking at the heart failure journey, at least with the paradigm heart failure, we had some significant impact on the quality of life, as well as the very important endpoint of mortality and heart failure hospitalization, which was tackled in the paradigm heart failure in chronic heart failure patients. But mind you that in the paradigm heart failure, acute decompensated heart failure was excluded from such trial. And we were all very interested to see some data for patients having acute heart failure, until we got data from two important trials, the Pioneer heart failure and the Transition. In the Pioneer, which was comparing sacubitril/valsartan versus enalapril on the effect of N-terminal proBNP in patients stabilized from an acute heart failure episode, the time average proportional change in N-terminal proBNP from baseline at 4 months and 8 months was significantly lower by approximately 29% in favor of sacubitril/valsartan versus enalapril. Both of them did reduce the N-terminal proBNP, but there was a significantly greater reduction using sacubitril/valsartan, which actually started to appear as early as 1 week of starting the therapy and persisted throughout 8 weeks. There was an additional 46% relative risk reduction in exploratory serious clinical composite endpoint of death, heart failure, rehospitalization, LVAD, and listing for transplant. On the other hand, the Transition, which was actually comparing initiation of sacubitril/valsartan in hospitalized patients with heart failure, reduced ejection fraction after hemodynamic stabilization. Actually, in this trial, there was initiation of sacubitril/valsartan in a wide range of heart failure, reduced ejection fraction patients early after acute decompensated heart failure event in hospital or shortly after discharge was feasible and overall was well. This was clear in the primary endpoint on target dose of 200 milligrams BID of sacubitril/valsartan at 10 weeks, or some of the other secondary endpoints that were listed. So with the paradigm heart failure and with Transition and Pioneer, the heart failure circle was actually can we start sacubitril/valsartan in de novo heart failure patients or not? And we know the percentages of naive or de novo patients in the Pioneer heart failure, Transition, and the Proof heart failure. In the Transition, de novo patients were approximately 29%, approximately 35% in the Pioneer heart failure, and near to 15% in the Proof heart failure trials. In the Pioneer heart failure, on the other hand, there was a pre-specified subgroup analysis of this trial. And as you can see here, changes in the N-terminal proBNP concentration in the no ACE or ARB group versus the yes ACE or ARB group, we'll find that in both of them, there was a significant reduction in the N-terminal proBNP in favor of both enalapril and sacubitril/valsartan led to a significant reduction in the N-terminal proBNP, but this was significantly better with the sacubitril/valsartan, whether the patient was taking ACE inhibitor or ARB or was naive for both. In addition, Kaplan-Meier's estimated cumulative incidence of cardiovascular death or hospitalization for heart failure showed also improvement if you're giving the patient sacubitril/valsartan, whether the patient was taking ACE or ARB or was not taking them at start. And they concluded in this pioneer heart failure subgroup analysis that in patients admitted with a primary diagnosis of acute decompensated heart failure, irrespective of prior ACE or ARB exposure, sacubitril valsartan was safe and well tolerated. And when compared to a conventional RAS antagonist, in-hospital initiation of ARNI resulted in a greater reduction in N-terminal pro-BNP levels, as well as a reduction of rehospitalization for heart failure. On the other hand, a subgroup analysis of the transition study was actually also very, giving some very important information. Patients with de novo heart failure were more likely to achieve and maintain target doses of sacubitril valsartan by week 10 compared to those with prior heart failure. And this was a bit of a strange point. And sacubitril valsartan should be considered, according to the study, as first-line therapy in de novo patients hemodynamically stabilized after an acute decompensated heart failure event. And for some time, and before the results came out of the proof heart failure, everyone was talking about, at least those who used it and were impressed about the results of the paradigm heart failure, and when they started using it on the patients, started to be very impressed about the outcomes of the patients. But we did not have a significant information regarding the mechanism by which such medications will lead to such an improvement. We know from different studies now that the N-terminal pro-BNP is significantly reduced when you're using sacubitril valsartan. This is even better than when you're using an ACE inhibitor, for instance, like enalapril. But we didn't have too much information regarding what's happening and the ventricular remodeling, what's happening to it using such a medication. In the proof heart failure, the primary objective of the study was to examine the association between changes in concentration of N-terminal pro-BNP and cardiac remodeling, assessed by echocardiographic parameters of volume, left ventricular ejection fraction, left atrial volume index from baseline to 1 year. And as we can be seeing here, there were some patients, at least a quarter of the study population, experienced a left ventricular ejection fraction increase by approximately 13% at 12 months. On average, by 12 months, there was an improvement in left ventricular ejection fraction by 9.4%, and there was an improvement over time of ejection fraction, a significant reduction in left ventricular end diastolic volume index, another significant reduction in left ventricular end systolic volume index using using sacubitril valsartan, and this was statistically significant. Reverse cardiac remodeling also affecting the left atrium was also seen, and there was a significant reduction in left atrial volume index, and the E over E prime showing the diastolic dysfunction was actually also improved using sacubitril valsartan, and this was statistically significant. So even in subgroups of interest, such as those having new onset heart failure, who were actually also ACE or ARB naive patients, or those having a natriuretic peptide less than the inclusion criteria in the paradigm heart failure, or those who were not reaching target doses, the reverse cardiac remodeling was quite impressive and seen in all of these groups, as shown here from the data that we are showing. There was also a very impressive rapid and sustained improvement in the quality of life using the Kansas City Cardiomyopathy Questionnaire. And we can see that actually the effects were seen as early as 2 weeks from starting therapy. And they concluded from the proof heart failure that in this study of patients with heart failure reduced ejection fraction, treated with sacubitril valsartan, reduction in N-terminal pro-BNP was significantly associated with reverse cardiac remodeling, and that the degree of reverse remodeling demonstrated may help to explain how sacubitril/valsartan reduces morbidity and mortality in patients with heart failure, reduced ejection fraction, and that reverse cardiac remodeling was compatible in each subgroup of interest, such as those having new onset heart failure and those who were ACE or ARB naive patients. So what about the guideline recommendations? Actually, the guidelines changed according to the data we are having. And in the American guidelines, they recommend clearly that sacubitril/valsartan or ACE inhibitors or ARBs for patients with heart failure are class 1 recommendation. They recommend sacubitril/valsartan in conjunction with evidence-based beta blockers and MRAs in patients with chronic symptomatic heart failure, reduced ejection fraction, New York Heart Association, class 2 or 3, who tolerate an ACE inhibitor or an ARB. And my conclusion for this presentation, that new therapies for heart failure are needed that can more fully address factors responsible for underlying progressive cardiac dysfunction. Sacubitril/valsartan significantly reduced death from cardiovascular causes or first hospitalization for heart failure, all-cause mortality, and improves patients' quality of life. Initiation of this medication in a wide range of heart failure reduced ejection fraction patients early after acute decompensated heart failure, even in hospital or shortly after discharge, was feasible and overall well tolerated. Improved heart failure study of patients with heart failure reduced ejection fraction treated with sacubitril/valsartan. Reduction in N-terminal proBNP was significantly associated with reverse cardiac remodeling, as we have shown, and that the guidelines recommendations for ARNI for treatment of heart failure are actually in line with the trials that we are having on hand. So my final words, that sacubitril/valsartan is definitely an essential heart failure intervention, and I was actually impressed by the comments that we're talking about. Should we be revising our indications for ICD implantations in such patients with heart failure or not, given the fact that we are having more and more effective medications? Thank you very much.
Thank you, Hisham, for this wonderful lecture. And a summary of this, that you have now the drug which is essential in chronic heart failure reduced ejection fraction. Number 2, it improve quality of life, reduce sudden death, reduce recurrent hospitalizations, and you illustrated the paradigm and other trials such as Transition and Prove It and Pioneer, that you shouldn't wait after if the patient is in failure in the hospital and then is off drugs and IV and is dehydrated. Now it's no congestion, and you can start this drug. And the reverse remodeling. Let me ask you about the guideline. Guideline 2016. What is the patient profile when you are allowed to start the ARNI from de novo? I mean, it is in all patients, or have a patient profile? If it is related to the echo, it's related to the biomarkers. How can you define the patient who should start with ARNI?
Okay, thank you very much for this nice question. Actually, it depends whether you follow the European guidelines or the American guidelines. The American guidelines are more liberal, and I actually like more the American guidelines because I think they help the patients, specifically in such situations. I guess that we should not be waiting until patient receives ARB or ACE inhibitors, and then when they are still symptomatic in spite of taking such medication, then you should be considering ARB. I think you should start thinking of ARNI or sacubitril/valsartan. I think that we should be starting such medications early, and this is what I'm doing in my clinical practice. If the patient is having heart failure and ejection fraction below 40%, and the patient is symptomatic, if the patient is on ACE inhibitor and doing fine, I will continue. But if he's coming de novo and his ejection fraction is below 40% and the patient is symptomatic, I can be having the option to start from the very beginning to give him.
The second question on practice: if the patient, I know that it should be given to the patient with blood pressure more than with 100 or more. If the patient develop hypotension, what are the prerequisites to stop this? Can you stop it or decrease other drugs, or what you are going to do?
This is a very important question. What I usually do is that I usually calculate the dose of diuretic that I'm giving when I'm starting circulatory valsartan. Because one of the major issues that lead to hypotension is that you do not adjust the diuretics. And mind you, that this molecule actually leads to some diuresis. And in many of the patients, I can be decreasing the dose of diuretics after some time. So if you are cautious when you are starting and giving the doses as per insertion leaflet and per guidelines, and you are adjusting the diuretic dose, probably you will not be getting too much hypotension. Of course, we know in the studies that this happens relatively, it's not a rare issue, but I mean, if you are following up the patient closely and you are trying to adjust the dose of diuretics as much as possible, the incidence of hypotension, symptomatic hypotension, will be much less. So what I do is that I start the dose and I usually reduce the diuretic dose when starting, and I follow up the patient. If the patient develops hypotension, I will probably, definitely depending on the degree, but usually what I'll do, I will reduce the dose of sacubitril valsartan.
دكتور محمود.
والله أنا بحب أشكر الدكتور هشام على his great presentation. الحقيقة وأنت سألت نفس الأسئلة اللي كنت أحب أسألها. يعني I think يعني your presentation was great وبشكره وما أعتقدش عندي أسئلة أكتر من الأسئلة اللي أنت سألتها.
Thank you, Dr. Hisham. Thank you very much.
Thank you very much.
شكرا دكتور هشام. ماشي. مساء الخير. زي ما بيقولوا ختامها مسك. أنا يسعدني أن أنا أقدم دكتور محمد سيمي الأخ العزيز استشاري القلب في معهد القلب القومي. والحقيقة هو an excellent speaker وأنا بستمتع لما بسمعه ودايما متابعه. فدكتور محمد سليم هتتكلم على الهايبرتنشن النهارده وغير اللي مكتوب قصادي في البروجرام. Hypertension, the magnitude of the problem. تفضل دكتور محمد.
Thank you very much, my dear Professor Dr. Mahmoud Hassanein, for this very kind and lovely introduction. Thank you, Dr. Sobhi, for inviting me for this elegant meeting of the ACC edition in Middle East. It's almost my honor and pleasure to be with you. My talk, New Concepts in the Treatment of Hypertension. And this session is a symposium sponsored by Novartis. The magnitude of the problem of hypertension worldwide, based on the office blood pressure, the global prevalence of hypertension was estimated to be around 1.13 billion. This estimation was at 2015, with a prevalence of over 150 million in Central and Eastern Europe. And according to these statistics, global age standardized prevalence was 24% in men and 20% in women, respectively. This high prevalence of hypertension is consistent across the world in different countries, irrespective of the income status, whether lower, middle, or higher income countries. And as population age, adopt more sedentary lifestyles with bad dietary habits and the increase in their body weight, the prevalence of hypertension worldwide will continue to rise. And it is estimated that there will be more increase, around 20% by the year 2025, to reach a total population of hypertension of 1.5 billion. And of course, elevated blood pressure was the leading global contributor to premature death, accounting for almost 10 million deaths as the statistics of 2015. The rule of thumb, with each increase in 20 millimeter mercury in systole and the 10 millimeter mercury in diastole, there is a doubling of the cardiovascular mortality risk, starting from systolic of 115 up to 175, and starting from diastolic of 75 up to diastolic of 105. These are some Egyptian data about the prevalence of hypertension, according to Professor Mohsen Ibrahim et al. In 2014. It was estimated that about 15 million Egyptians with hypertension, 7 million Egyptians will be in the need of lifelong drug treatment and regular follow-up. Below the age of 60 years in adults, the prevalence is 26, and the prevalence reaches almost half of the population above the age of 60 are hypertensives. Also, in Egypt, Egyptians seem to belong to the salt-sensitive group. Salt sensitivity is estimated in 30% of non-hypertensive individuals and almost 50% of those with hypertension. Only less than 40%, exactly around 37.5%, aware that they are hypertensive. And the rate of control among those aware of being hypertensive are only 8%, which is a very low rate of blood pressure control. And according to the Egyptian Hypertension Society, blood pressure treatment goals will be less than 150/95 in those with low risk and in elderly above the 65 years of age, and will be less than 140/90 if there are two risk factors or in diabetic patients, CKD, target organ damage. In case of proteinuria, heart failure, LV systolic dysfunction, CKD or diabetes, the target or the goal will be less than 130/80. It is noteworthy that beta blockers in Egypt are still very widely used as antihypertensive drugs. We can go through a history of hypertension treatment. It is surprising that only about 50 years ago, hypertension was considered an essential malady and not a treatable condition, which means that some can consider in 1960s, the early 1960s, that it is a physiological condition, especially in the elderly, that will not need it to be treated. But starting from mid-80s and mid-90s, there are epidemiological studies, observational studies, and intervention clinical trials that showed that with a reduction of blood pressure, there is a significant reduction of hard endpoints of death, stroke, retinopathy, myocardial infarction. And there are, at that time, and especially at the beginning of this millennium, landmark trials in the elderly and in different risk group patients like Olahat, like the HIVID, and like the most recent trial which changed the American guidelines is the SPRINT trial, which showed that still we can gain more benefit if we can reach by the systolic blood pressure of less than 120. And this is the intensive treatment group compared to the standard group, in which the goal is to be less than 140. The primary outcome of myocardial infarction, acute coronary syndrome, stroke, heart failure, or cardiovascular mortality are significantly less in the intensive treatment group compared with the standard treatment group. What do the guidelines say? First, the guidelines, the European guidelines in 2018 underscore the preferred use of two-drug combination therapy for the initial treatment of most people with hypertension. And this dual combination of drug, including either ACE or ARB, plus calcium channel blocker or diuretic. Consider monotherapy only in low-risk grade 1 hypertension, in which systolic blood pressure less than 150 millimeter mercury, or in very old people above 80 years of age, or in frail patients. Step 2, if they are not controlled with this combination, we will go for triple combination. It is very simplified algorithm. And the core of the strategy is the combination between RAS blockade and or calcium channel blocker and diuretic. Step 2, in case of bad control or uncontrolled blood pressure, is a triple combination of the RAS blockade, calcium channel blocker, and diuretic. then still blood pressure is not controlled, so it is a resistant hypertension in which triple combination plus spironolactone in a dose of 25 to 50 milligram OD or other diuretic, alpha blocker or beta blocker. And here at this step, consider refer to a specialized advanced investigations and experience. Beta blockers could be added at any treatment step from step 1 to step 3 when there is a specific indication only for their use. For example, heart failure patients, patients with ischemic heart disease or angina, post-MI, atrial fibrillation, or younger women at childbearing period or planning for pregnancy. Also, in the American guidelines, initiation of antihypertensive drug therapy with 2 first-line agents of different classes, either as a separate agent or fixed dose combination, is recommended as class 1 in adults with stage 2 hypertension and an average blood pressure more than 20/10 millimeter mercury above their blood pressure target. Single antihypertensive drug is reasonable in adults with stage 1 hypertension when blood pressure goal is less than 130/80 with dosage titration and sequential addition of other agent to achieve blood pressure target, and this is class 2A. And for the first time in the guidelines, in the European guidelines, it was mentioned clearly that it is recommended and preferable for combination of drug, not free combination, but it is preferably as a single pill combination, highlighting the importance of the compliance and long-term adherence. The advantage of combination therapy, of course, is the synergistic effect between different class, attenuation of different adverse effects, encouraging the adherence, greater probability of achieving the target blood pressure in patients with higher blood pressure value, prompt or rapid response in a large number of patients, potentially beneficial, especially in high-risk patients who are vulnerable to major adverse cardiovascular outcome. Of course, the advantage of combination therapy, we have main 3 mechanisms for hypertension: activation of sympathetic nervous system, activation of the RAS system, and abnormal handling of the total body sodium. And if we will go for combination therapy, we can get more than one mechanism with better and strong and robust control of the blood pressure. If we will compare between the titration of a single agent or combination of 2 different classes, the extra blood pressure reduction from combining drugs from 2 different classes is approximately 5 times greater than doubling the dose of one drug. It's very important. Five times more effective in controlling blood pressure, more than doubling the dose of one drug. And also, addition of 2 different classes by moderate doses will lead to less side effects and therefore better tolerability of the combination drugs. If we compare the single pill combination versus free drug components, we can achieve about 29% improvement in the compliance and persistence with therapy, which will be reflected on better blood pressure control. And this analysis from almost 6 large retrospective studies, including data from more than 30,000 patients. It's very important. So in the guidelines, European guidelines, recommendation of combinations of 2 antihypertensive drugs at fixed doses in a single tablet may be recommended and favored and preferable because reducing the number of daily pills improve adherence, which is low in patients with hypertension. Okay, which combination therapy? This is a new data from REACH registry, including more than 40,000 patients. The results from this contemporary large cohort of outpatients with high cardiovascular risk show that the incidence of major adverse cardiovascular events was significantly lower in patients on angiotensin receptor blockers compared with angiotensin converting enzyme inhibitors, 29.2 versus 33.4, especially in patients with established cardiovascular disease. Before this REACH registry, we know very well that the ACE inhibitors are preferable over ARBs and ARBs are indicated as an alternative therapy in case of ACE inhibitor intolerant patients. The results from this contemporary REACH registry with high cardiovascular risk cohort of patients show that the incidence of major adverse cardiovascular events was significantly lower in patients on ARBs compared with ACE inhibitors, especially in patients with established cardiovascular disease, which this data is new data contrary to our belief or the previous guidelines. And the results suggest that ARBs should be preferred to ACE inhibitors in patients with previous history of cardiovascular disease. Here we have some Egyptian experience about the effectiveness and tolerability of fixed dose combination of amlodipine, valsartan, or Exforge. We have here significant reduction in blood pressure after 12 weeks with single pill combination of Exforge in 6 categories of patients: in patients with dyslipidemia, patients with coronary artery disease, diabetic patients, patients with hyperuricemia, patients with history of heart failure, patients with COPD, asthma, and respiratory illness. And in all these subgroup of patients, there is a significant and statistically significant reduction of both systolic and diastolic blood pressure, ranging from 45 in systole and about 22 or 23 in diastolic blood pressure, very significant decrease in blood pressure. And also here there is an incremental antihypertensive efficacy of this combination of Exforge, amlodipine, valsartan, irrespective of the previous monotherapy, whether the patient beta blocker or calcium channel blocker or a single RAS blockade or diuretic. There is a significant and incremental decrease in the blood pressure when the combination of valsartan amlodipine was added in a patients with poor control on monotherapy. Here is a recent published trial in last February, SMART trial. This is the first Egyptian trial on Exforge HCT on hypertensive patients uncontrolled on dual therapy. It includes more than 1,000 patients from different 47 centers in Egypt, were treated according to the local prescribing information. The current study aimed to evaluate the efficacy and tolerability of this triple combination of amlodipine, valsartan, and hydrochlorothiazide as a single pill combination according to the most recent guidelines in patients with hypertension in Egypt who were uncontrolled on any dual therapy. The rationale that, according to the last presidential product of 100 million wellness, around 30% of Egyptians have raised blood pressure. 1/3 of them will need triple combination to reach blood pressure goal. And not even a single study have been conducted on such Egyptian population using triple combination therapy. And these are the characteristics or demographics of the patient. The mean age is around 54. Females are very well represented, almost 40%. Family history of hypertension in 2/3 of the patients. The mean systolic blood pressure is 165 as an inclusion criteria. Diastolic 100. Duration of hypertension was around 8.4 years. Around 1/3 of the patients were smoker. 27% of patients were obese. 38% diabetics, dyslipidemia in 40%, coronary artery disease in 10%, heart failure in almost 6%, and stroke in 1.3%. Here is the primary endpoint of the SMART trial is evaluation of the efficacy of this combination at 2 weeks and 12 weeks. At 2 weeks, we have significant reduction of systolic blood pressure, mean reduction of about 28 millimeter mercury, and in diastolic is around 15 millimeter mercury. We started by a mean of 165 systolic over 100 diastolic, and by the end of 2 weeks, very early, we find that the systolic mean of 137 over 85 diastolic, and after 12 weeks, 3 months, the systolic blood pressure became less than 130, and diastolic blood pressure was around 80. Very significant and very important results. Showed significant reduction observed as early after 2 weeks and continued at the end of the study. And also, we can say that out of 10 patients reached blood pressure goal, almost more than 90% diastolic less than 90, around 78% systolic less than 140, and both of them in around 76% of patients. And also, this SMART trial had a very good safety and tolerability assessment of the serious and general adverse events, ankle edema, and tolerability assessment was conducted at each visit by calculation of the incidence of these adverse events in frequency tables in relation to the severity, mild, moderate, severe, or life-threatening, for example, in case of angioneuritic edema. And overall tolerability was assessed depending on physician assessment and at the end of the study. As you see here, in almost more than 95% of patients, the X4 HCT showed excellent and good tolerability reported in this study. And this reflects the bulk of evidence of the valsartan across the whole cardiovascular continuum, starting from the improvement of the endothelial function and tissue injury, atherosclerosis, reduction of new onset diabetes, improvement in the remodeling following myocardial infarction, reduction of stroke and heart failure hospitalization up to the end stage heart disease. And the multiple trials showed the beneficial effect of valsartan across the whole cardiovascular continuum. I want to remind you, but by some of the merits of this molecule, you can remember that in value trial, when valsartan compared to amlodipine, there is a significant reduction of new onset diabetes, around 23% of the new onset diabetes. Also, the impressive results of the valsartan in post-MI in Valiant and in heart failure patient in VALHEFT, and the very good nephroprotective effect of valsartan, decreasing the proteinuria, and even significant number of patients in this study coming back again to the normal albuminuria compared to amlodipine in this trial. And if we will compare the bulk of evidence, this is my conclusion, in different, or these are the 7 principal ARBs. We can say that the bulk of evidence regarding the trials, regarding the evidence, regarding the number of patients is in favor of valsartan, which were studies in almost more than 10 trials, including different group of risk patients and different ages and different profiles, and reaching almost approaching 60,000 patients showed the beneficial effect of valsartan. Thank you for your attention.
محمد دكتور محمد، انا بشكرك على this great presentation. حقيقه هي some comments بالنسبه للاعداد البريفالنس اوف هايبرتنشن ان ايجيبت. هو طبعا البروجكت بتاع الدكتور محسن ابراهيم ده كان في التسعينات، لكن اكيد البريفالنس اوف هايبرتنشن زاد، وكان في سيرفي اتعمل مع المينستري اوف هيلث والدبليو اتش او 2011 2012 قال البريفالنس وصل ل 40% of the adult population of Egyptian patients have hypertension. الملاحظه الثانيه، الهايبرتنشن جولز set by the Egyptian Society of Hypertension هي يعني relatively عاليه، اللي هو لو له ريسك 150 على 95، بينما بعد السبرنت ترايل زي ما شفنا اليوروبيان سوسايتي اوف كارديولوجي قالت التارجت 140 على 90، واذا ذا بيشنت كان توليريت ذا ميديكيشنز ممكن تنزل ل 130 على 80. الامريكانز قالوا على طول الجول هو 130 على 80. الملاحظه الثالثه اللي انا بقولها ان الديوال كومباينيشن ده should be يعني هو الرول in treatment of hypertensive patients. يعني هنقول most or majority of hypertensive patients should be started on dual combination therapy. The role of monotherapy is very limited. يمكن في الجماعه الالدرلي الفيري frail patients. وونس العيان بعد 4 أسابيع بالكثير not respond على dual combination، انا بنقل على طول على triple combination، وده بيجيب نتيجه زي ما حضرتك ما قلت يمكن في اكثر من 90% من العيانين they will respond to this treatment. These are my comments. ايه راي حضرتك في
يا فندم؟ انا موافق حضرتك تماما، والحقيقه برضو الريكومنديشن اللي هي 150 95 انا ذكرتها زي ما هي، بس انا طبعا ليا تحفظ عليها، يمكن بس في الفريل بيشنتس او الفيري الدر لكن ما عدا ذلك دي تعتبر الحقيقه تارجت عالي شويه ان كومباريزون للامريكان ولليوروبيان جايد لاينز. النقطه بس اللي حضرتك قلتها ان الاحصائيات اللي هي في التسعينات، لا الاحصائيات اللي انا جايبها دي 2014 وقسموا البريفلنس فوق سن 60 سنه، لقوا البريفلنس هايبرتنسيف 50% من الايجيبشنز فوق سن 60 سنه عندهم هايبرتنشن، فدي كانت ابديتد من 2014. والباقي طبعا
ده كان سيرفي حديث اللي حضرتك بتقول عليه ده هو اللي هو 2014
2014
ده مينستري اوف هيلث ولا كان WHO ولا السورس يعني؟
كان الدكتور مجموعه الدكتور محسن ابراهيم بالتعاون مع مينستري اوف هيلث.
اوكي.
دكتور سليم طبعا زي الدكتور محمود واشاد، انا بايد برضه، بس انا اي ثينك تو اد يو ان احنا خلاص احنا in the era of combination therapy except يعني الكيموثيرابي. ونمبر 2 التارجت we have to know، وبعدين نمبر 3 you have to look to the risk category، لان الريسك كاتيجوري مع الجريدز is very important. It's not only the number، يعني ممكن تلاقي mild hypertension with high risk category يبقى مش مفيش لايف ستايل، يبقى لايف ستايل بلس actual intervention. الكويشنز نمبر 4 which combination انت you said that ACE or ARBs with diuretic او calcium channel blocker. Can you differentiate patient profile taking ARBs او ACE with diuretics او ACE ARBs with calcium blocker which is which؟
والله هو حضرتك في اليوروبيان جايد لاينز ما حددوش، يمكن اللي فرق شويه في البريتش جايد لاينز لما قالت ان لما يكون البيشنت فوق سن 55 بيفضل ان الكومبينيشن يكون مع الكالسيوم شانل بلوكر. وفي الفيري ايرلي بيستفيدوا جدا من الثايزايد دايوريتكس او من الكلورفيريدون، لكن ما عدا ذلك في اليوروبيان ما حددتش ويتش بيشنت بروفايل. لكن كل ما كان البيشنت معرض لان عنده نوع من الفاسكولار ستيفنس ووايد بالس بريشر، اي ثينك he will gain much benefit من الكومبينيشن مع الكالسيوم شانل بلوكر اكتر من الدايوريتكس.
طيب الهايبرتنشن فيها central aortic pressure وفي dipping during الامبلاتوري، في blood pressure variability pressure. هل you have to change drugs according to these items or it is just a drug for the number and the compelling indications?
Yes, it's a very good question Mr. صبحي. هو الحقيقه الكونسبت بتاع السنترال اورتيك بريشر ده جاي من الكافيه ستادي اللي ورد ان احنا مش بس الضغط هو الضغط اللي احنا بنقيسه في الاوفيس، لا ده السنترال اورتيك بريشر، ولكن ان في بعض الدراجز بتاثر على السنترال اورتيك بريشر اكتر من دراجز ثانيه، وكان اشهرهم الداي هيدروبايريدينز. دي كانت بتاثر اكتر على السنترال اورتيك بريشر، ويمكن دي عشان كده وارد سوبريوريتي في ريدكشن اوف ستروك في الكافيه ستادي. بالنسبه للديبنج الحقيقه انا ده دايما بشوفه في العيان اللي هو بيجي لي الاوفيس بلاد بريشر بتاعه كويس، لكن الاقي عنده ايفيدنس اوف تارجت اورجان دامج. فده حتى لو انا قدامي الضغط متظبط اي هاف تو جو فور امبيولاتوري بلاد بريشر مونيتورنج، ولازم اعمل كومبانيشن وابقى مور اجريسيف في الكنترول بديفرنت كلاسز بقى، يعني مفيش حاجه مور سوبيريور عن حاجه في موضوع الديبنج. برضه من ضمن الحاجات اللي بتقلل البلاد بريشر فاريابيليتي الكالسيوم شانل بلوكر والاربس بتقلل الاكسكورشن او البلاد بريشر الديفرنس ما بين البيك والتراف.
حضرتك برضه قلت ان الدكتور محمود سال انت الفولو اب عشان تريسبونس بلاد بريشر، يعني انت بتوصل ماكسيمال توليريتد دوز زي مثلا فالسارتان with امريدوبين يعني 160 10 ده الماكسيمم. لو خدت 160 12.5 are you going to allow to add مثلا امريدوبين 5 not to increase the dose of diuretics او to increase the dose of the valsartan؟ يعني ايه الراشونال behind decreasing each one of drug in a single pill combination؟
هو الحقيقه اللي برضه احنا سام تايمز بنبقى محكومين بالافيلابل دوزز كومباينيشن اللي موجوده في الماركت. يعني انا ما عنديش هنا غير ال 560 على 12 ونص او ال 10 160 على 25. فانا ممكن اضيف بقى زي ما حضرتك قلت كده انذر كومبينيشن من بره لو انا لسه مش مظبط. هو اهم حاجه في الموضوع ان انا بحاول في كل بيشنت اشوف which is a more contributing. قد يكون هو الباثولوجيكال ميكانيزم المسؤول، هل هو فاسكولار ستيفنس، هل هو increase the plasma volume and fluid retention. فبحاول بركز على كل components according للدراج اللي انا عايز ازوده.
بس يمكن الفالسرتان الايفكت بتاعه ان هو عند he has trial، يعني هو very strong والمولكيول سبيسيفيك، ونمبر 2 ان هو في البوست مايكارديال انفارشن زي حضرتك قلت في الفاليانت وفال هيفت قلت ده في الهارت فيلير، والفاليو في البروتكشن اللي هو 320 والانسولين دايبيز،
والمارفال في النيفرو بروتكشن،
والمارفال في التنشن. ثانك يو فيري ماتش دكتور محمد. دكتور محمود I think we have to close.
اعتقد ان تايم از اب، وبشكر الدكتور محمد سليم،
بشكر
وبشكر الاودينس اللي هم صبروا معانا وسيروا معانا لغايه دلوقتي.
اسمح لي يا محمود ان انا
طبعا اتفضل.
دلوقتي احنا الاي سي طبعا بشكر دكتور محمود الشيرنج سيشنز الهارت فيلير والنوفار سيمبوزيوم، والسبيكر دكتور سليم والدكتور هشام، وكل السيشنز. احنا عندنا النهارده كان في 3 سيشنز. فيرست سيشن ان اكيد كوروني سيندروم كومبلكس اناتومي هاي بليدنج ريسك، سيشن الثاني كان هارت فيلير، سيشن الثالث على نوفار سيمبوزيوم اسينشال انترفنشن والكومبينيشن ثيرابي. الحقيقه الاتندي كانوا 440 وكان عندنا 490 كانترز، ودي حاجه يمكن يعني ما حصلتش قبل كده، ان انت عندك 49 كانترز inside the webinar for 3 hours، وده انا يعني ريكوردد معانا ايكون لسه بعتها لي، وانا اسمحي لي ان انا منشن ذس ذا فيرست ويبينار ده this is the success of the first webinar، واحنا we have also 3 webinars in the next 3 months. يعني every month we have a webinar ACC regional Middle East ACC together with the Middle East doctors والEgyptian والAmericans belonging to the ACC. أنا بشكر حضراتكم.
Congratulations يا باشا. Congratulations.
Thank you very much. Bye bye.